So both of these conditions are very much common in day-to-day clinical practice. First, I will show you the video. Then we'll go through the case summary. Then detail of the case. So in both scenarios, I'll be first showing you the video, which will be showing clinical examination and history taking, followed by the summary of the case, and then we'll discuss regarding the case. Okay. So let's start the screen. I hope this time. Uh, is it visible in the screen?
Yes, it is visible.
Okay, I'm preparing it. And the audio is also visible, audible? Urmila Shrestha, वर्ष 34. Is the
Audible, audible.
okay, good.
It is audible.
So young female came to the clinic. Okay, she has told her friend to get outside, but stay outside. कमरको तल्लो पुच्छर हड्डी दुख्ने रोग कति भयो दुखेको हजुरलाई 2 महिना भयो 2 महिनामा यो बारेमा यो दुखाइको बारेमा मलाई सबै कुरा भन्नुस् न कसरी सुरु भयो यो दुखाइ के गर्दाखेरि यो दुखाइ बढ्छ के गर्दाखेरि यो दुखाइ घट्छ र तपाई म कहाँ यहाँ 2 महिना भित्र आउँदाखेरि तपाईले अरु डाक्टरहरु कहाँ जानु भएको थियो भए के सल्लाह दिया छ मलाई यी कुराहरु अलिकति भन्नुस् त कसरी सुरु भयो 2 महिना अगाडि म बच्चाहरुसँग हजुर अनि ओर्लिँदाखेरि त्यो ओह्रालोमा छिपेर त्यसमा पछाडी तपाई हाइकिङमा आइराख्नु भयो ओर्लिँदाखेरि तपाई लड्नु भयो लडेर पछाड्नु भयो पछाड्दाखेरि यही ठोकेको थियो त्यो ठोके बेलादेखि नै त्यो बेलादेखि दुखेको दुखाइ छ त्यो बेलामा दुखेको छ र यो दुखाइ कस्तो छ भित्रबाट केही समातेको जस्तो छ कि पोलेको जस्तो छ कि झन्झनाएको छ कि भित्रबाट दुखिरहन्छ भित्रबाट दुखिरहन्छ र यो दुखाइ तपाईलाई सुन्ना भनेको दुख्दै नदुख्ने हो र 10 भनेको यति धेरै दुख्ने हो भए चाहिँ तपाईले यो दुखाइलाई कति नम्बर दिनुहुन्छ सुन्ना भनेको दुख्दै नदुख्ने 10 भनेको सबसे धेरै दुख्ने अनि तपाईले कति नम्बर दिनुहुन्छ यो दुखाइलाई त्यस्तै 7 छ कहिले काहीँ चाहिँ फेरि दुख्ने पनि हुन्छ सो सो तपाईलाई धेरै दुख्ने भनेको 7 तर कम दुख्ने भनेको 2 सम्म हुन्छ र कहिले यो धेरै दुख्छ के गर्यो भने तपाईलाई दुखाइ बढ्छ त बहिनी यसो धेरै बेर कुर्सीमा बस्न सक्दिन कोल्टे परेर बस्नुपर्छ कि अगाडि झुकेर बस्नुपर्छ कस्तो कोल्टे भन्नाले कि यसरी बस्नु पर्यो कि अगाडि झुकेर तपाईलाई कुर्सीमा बस्यो भने दुख्ने हो त्यसपछि यो बाहेक अरु के गर्दाखेरि दुख्छ त्यो कुर्सीमा बस्दा र गर्दा दुख्ने हो तर सुत्दा हिँड्दा चाहिँ दुख्दैन तपाईले अघि भन्नुभयो तपाई अफिसमा रिसेप्सन काम गर्नुहुन्छ भन्नुभएको थियो त्यो बेला पनि कुर्सीमा बसेर दुख्छ र के गर्नुहुन्छ तपाई कुर्सीमा बसेर दुख्यो भने चाहिँ के गर्नुहुन्छ धेरै बेर बस्यो भने दुख्छ म दुखे चाहिँ उठ्छु उठेपछि आराम कम हुन्छ यसरी कोल्डिङै बस्छु सो तपाई कुर्सीमा बस्यो भने दुख्ने तर उभियो भने या पोजिसन चेन्ज गर्यो भने तपाईलाई अलि आराम हुन्छ र अरु के गर्यो भने आराम हुन्छ त अरु हिँड्दा सुत्दा त त्यस्तो दुख्दैन ओके बस्दाखेरि त ओके तपाईलाई हिँड्दाखेरि पनि केही समस्या छैन सुत्दाखेरि पनि केही समस्या छैन र कुनै दबाई खायो भने यो दुखाइ कम हुन्छ पेनकिलरहरु खायो भने चाहिँ कम हुन्छ पेनकिलर खायो भने कम हुन्छ र तपाईले यो 2 महिनामा चाहिँ यो पेनकिलरै बसिराख्नु भएको छ कि अरु कुनै उपचार गर्नु भएको छ अनि 2-3 दिनमा एकचोटी ओके अनि तपाईलाई चाहिँ कुनै घरमा कसैलाई बाथरोगहरु त्यस्तो केही छ तपाईको दिदी भाइ बहिनी या कसैलाई छ बाथरोग छैन त्यसको अनि तपाईको तौल अहिलेदेखि यस्तै नै हो कि अहिले मोटाउनु भयो कि पहिलादेखि नै यस्तो हो कस्तो हो तौल लास्ट नानी भएको कति वर्ष भयो त 5 वर्षदेखि तपाईको तौल त्यस्तै नै छ अहिले वात्त यो 2 महिना 3 महिनामा मोटो भएको होइन हैन र घरमा कसैलाई बाथरोग पनि छैन सो लड्नु भयो तपाई लडेपछि चाखमा ल्यान्ड गर्नु भयो त्यसपछिदेखि यो तल्लो भाग दुखेको दुखाइ नै छ हैन म एकचोटी तपाईलाई जाँच गर्छु है बहिनी एकचोटी आउनुस् त यहाँ घोप्टो गरेर बस्नुस् So I'm doing now physical examination of the patient. तपाईँलाई कहाँ दुख्छ एक्चुअली हातले देखाउनुहोस् त यही ठाउँमा मात्र दुख्छ कि यो सरेर यो तलतिर पनि आउँछ यही पोइन्टमा दुख्छ यो सरेर चाकतिर या खुट्टातिर दुखाइ आएको छैन है म एक्चुअली थिचेर हेर्छु है बहिनी So I'm doing palpation. दुख्यो यही थिच्यो भने दुख्छ ओके सो टेन्डरनेस इज पोजिटिभ सो म अलि यो चलाएँ भने So I'm doing manual movement of the lower end of the tailbone and she says that there is a painful हैन तर यहाँ दुखेको छ छैन So I'm pressing the piriformis area यहाँ दुखेको छ छैन SI joints एक्चुअली म जान्छु है तपाईलाई यहाँ थिच्न सधैँ दुख्यो ओके यो चलाउँदाखेरि पनि दुख्छ So manual movement of tailbone is painful palpation of tailbone is also painful. Actually, यतातिर बस्नुस् त नाक बन्द गरेर बुक बन्द गर्यो कसरी फुल्नुस् त So I'm doing valsalval maneuver. So valsalval test is negative. So basically, a young lady who came after 2 months of low back pain, most probably tailbone pain, and the diagnosis that I suspect is coccydynia. Okay. So हेर्नुहोस् त तपाईको यो माइन्ड चाहिँ तपाईँ भयो नि त तपाईको यो हड्डीमा लड्दाखेरि चाहिँ यो हड्डीमा चाहिँ चोट लागेको हुन सक्छ सो अहिले चाहिँ हामीलाई यो हड्डी यो पुच्छर हड्डी हो यो पुच्छर हड्डी तपाईँ लड्दाखेरि चाकमा ल्यान्ड गर्दाखेरि चाहिँ यो हड्डी अलिकति भाङ्गिएको जस्तो हुन सक्छ है आत्तिनु डराउनु पर्दैन आउनुहोस् त बसौँ सो यो तपाईले अघि भने जस्तै यो हेर्नुहोस् त यसमा चाहिँ सो तपाईको चाहिँ यसरी यो पुच्छर हड्डी हुन्छ यो पुच्छर हड्डी यो रातो देखेको पुच्छर हड्डी चाहिँ तपाईँ लड्दाखेरि चाहिँ तपाईको भाँच्यो या सड्क्यो त्यो घाउ हुन सक्छ तर अब अहिले 2 महिना मात्र भएको छ तपाईलाई यो समस्या भएको हैन अनि त्यो भएर तपाईलाई चाहिँ म अहिले चाहिँ मुखले खाने औषधि दुखाइ कम हुने औषधि 1 हप्ता 10 दिन दिन्छु जुन पहिला यसरी बस्यो भने आराम हुन्छ हो यसरी उल्टे परे नि भयो यसरी परेले आराम हुन्छ र अगाडि यसो झुक्यो भने आराम हुन्छ हो ओके सो यसरी सिधा बस्न साथै दुख्छ ओके र अहिलेलाई दुखाइ कम हुने औषधि दिन्छु 5-7 दिन त्यो सँगै म फिजियोथेरापी पनि पढाउँछु हजुरलाई कहिलेकाहीँ चाहिँ यो धेरै जस्तो फिजियोथेरापी गरेर पनि कम हुन्छ र यस्तो चकटी जस्तो हुन्छ एउटा यस्तो यो चकटी जस्तो हुन्छ यस्तो चकटीमा चाहिँ यहाँ पुवाल भएको चकटी हुन्छ त्यसमाथि तपाईले बस्नु भयो भने यसरी चकटीमा तपाईले यसरी बस्नु भएर यो चाकको भाग राखे पनि तपाईलाई अलि इजी हुन्छ है यो चकटी चाहिँ तपाईले मार्केटमा किन्न पाउँछ यसलाई चाहिँ यस्तो भन्छ कक्सिडाइनिया पिलो भन्छ तपाईले हेर्नु भयो भने सो कक्सिडाइनिया यस्तो पिलो हुन्छ हेर्नु त तपाई यो पिलोमा चाहिँ तपाईले चाक राखेर बस्नु भयो भने तपाईलाई अलि इजी हुन्छ सो म अहिले 1 महिना चाहिँ तपाईलाई चाहिँ मुखले औषधि खाउन दिएर फिजियोथेरापी गरेर र यो पिलोमा बस्न दिन्छु त्यसले तपाईलाई आराम हुँदै गयो भने म केही गर्न चाहन्न तर यो दुखाइ बढेर गयो 2 महिनामा पनि अब 1 महिना पनि ठीक भएन भने चाहिँ म तपाईको सानो सुई यो यसमा चाहिँ तपाईले चाहिँ यो सुईको माध्यममा हामी उपचार गर्छौं र सुईको माध्यममा उपचार गर्दा चाहिँ हामीले यो देख्नु भएको छ यो फोटो हेर्नुस् त तपाईको यो हड्डी यो भयो हैन यो हड्डीमा चाहिँ तपाईलाई यसरी तपाईको सानो सुई एउटा चाहिँ दिएर यो हड्डीको नसा लट्यो यो पहिला सुरु चाहिँ यो हड्डीको वरिपरि म सुई दिन्छु त्यसले पनि भएन भने चाहिँ म यो नसा एउटा हुन्छ यो दुखाइ लिएर जाने त्यसमा म सुई लाएर कम गर्छु र यो तपाईको ठुलो समस्या होइन यसलाई चाहिँ टेलबोन पेन पनि भन्छ या अंग्रेजीमा यसलाई कक्सिडाइनिया भन्छ धेरै जस्तो मान्छेलाई चाहिँ हामी सुई लाउँदैनौँ पहिला चाहिँ किन 2 महिना मात्र भएको भएर पहिला सुरु चाहिँ यो पिलोमा बसेर फिजियोथेरापी गरेर औषधि खुवाउन दिन्छु त्यसले भएन भने चाहिँ आइदर म तपाईलाई त्यो पुच्छर हड्डीमा स्टेरोइड भन्ने सुई अलिकति लगाइदिन्छु त्यसले पनि धेरै जनालाई त्यो र फिजियोथेरापी पनि पठाउँछु त्यसले भएन भने चाहिँ म यसरी तपाईलाई चाहिँ चाकको सानो हड्डीमा सुई दिन्छु है बहिनी ल चिन्ता लिनु पर्दैन है त थ्यांक यू धन्यवाद Okay, so this is just I think the voice was audible, no? How was the this time?
Yes, yes, it is. It is audible. Nice.
Okay, so let's go in some let's see some summary of the patient who has come. So my initial diagnosis was coccygodynia in this patient. So normally, if you see the case detail, 34 years young female came to the clinic with chief complaint of lowest back pain for 2 months, and her weight was 68. She is married with two children, and last children she was the youngest child is 5 years age, and she works as a receptionist. And the pain she was describing was in the lowest back, and it was sudden onset following a fall injury while she was going down hill hiking with her children. She fell down and landed on the in the butt. So since then she is having the lowest back pain or tailbone pain, and she describes the pain as deep aching in nature. The numerical rating scale was 7 in when the pain was maximum, and 2 when the pain was minimum, and it was non-radiating type of pain. Aggravating factors was mainly sitting position, and mainly she works as a receptionist, so she is having very much trouble while sitting and doing her job. And riding scooter also, she says that it tends to aggravate pain. And the relieving factor was she takes non-steroidal anti-inflammatory drug every 2-3 days to relieve pain. And she also changes her posture. She either leans forward or just elevate the right or left buttock when she has pain. So this also decreases the pain, and application of heat around the area of pain has also decreased the pain. And she gives history of fall injury exactly 2 months before the onset of lowest back pain, and she doesn't give any history of inflammatory arthropathy in the family. So on examination, patient points at the site of pain, that is just over the anal region, that is tailbone, and there was tenderness in palpation over the area, and manual manipulation of coccyx was also painful, and Valsalva test was negative. So with this clinical history and clinical examination, let's go into the case. So basically, coccygodynia is generally a very painful disorder of the tailbone, which is localized just above the anal region. As you can see in this picture, you can see the red area is the area where the patient will complain of pain in case of coccygodynia. Normally, cause is usually traumatic. So, in 99% of the cases, the onset of pain is followed by the is basically followed by the trauma, and it can be acute trauma, or while sleeping on a wet floor or while doing skating, you can just fall and land on your butt. Or it can be a chronic trauma like repeated sitting position, especially in the like receptionists, they tend to stay in the sitting position for a long period of time, so that is also one of the traumatic cause of the coccygodynia. Another is, like you may have noticed, she is a female, so every childbirth, during the childbirth, there is usually movement of coccyx at the junction of sacrococcygeal joint or intercoccygeal joint. So every childbirth is usually followed by the traumatic injury of the coccyx, especially if it is true when it is a difficult childbirth. So in case of female also, they are more prone to get coccygodynia. So another is cause is idiopathic. Idiopathic cause is less than 1%. So mainly they will have some kind of history of trauma, either acute trauma or repeated micro trauma before the onset of lowest back pain. And there are other risk factors, such as female gender tend to have more coccygodynia rather than in male. There are two reasons behind this. One is basically in female, the length of coccyx is slightly longer than in male. So female tend to have, and when they sit, the more pressure tends to exert in the coccyx. So that is one of the cause why female has more tendency to develop coccygodynia. Another is childbirth.
So as I've already explained, as the child comes out through the pelvis during normal vaginal delivery, there is movement of coccyx. So and that can cause, if there is repeated childbirth, or if there was a history of difficult childbirth or prolonged labor, then this can be one of the risk factor for developing coccygodynia later. So another risk factor is obesity. So obesity normally in male, if the BMI is more than 29.4, and in female if the BMI is more than 27.4, then that is also one of the risk factor. And other risk factor we should never forget is inflammatory arthropathy. So I have seen lots of patients with gouty arthritis or rheumatoid arthritis presenting with tailbone pain. So whenever patient comes with tailbone pain or any sign of enthesis, you always have to ask history regarding inflammatory arthropathy in the family or in the patient. So normally in coccygodynia or tailbone pain, the aggravating factor is usually sitting position. So as soon as the patient sits, so when they sit, our body tends to be balanced over the coccyx and to ischial tuberosity. So if there is any traumatic injury to the coccyx, then it will produce pain. And normally relief is provided by non-steroidal anti-inflammatory drug, or basically by adjustment of posture. So basically adjustment of posture means either leaning forward like the patient just showed you, or just elevating either right or left buttock can help to relieve pressure that is exerted in the coccyx. So that can relieve pain in majority of the patient. So in the lower part of the picture you can see this is the normal mode of mechanism of trauma, where they fall and land over the butt. So that may be the causative factor in case of development of coccygodynia. So normally examination and regarding examination, it is usually done in prone position as shown in the video. So patient usually points at the site of pain. Basically they can localize the pain, and it is usually just area above the anal canal. And the main test is palpation. So in palpation and manual mobilization of the coccyx or tailbone can be tender. A majority in majority of cases they are tender, but sometimes there can be absence of tenderness. So if there is any absence of tenderness and patient is pointing at the side, at the tailbone where the pain is, the condition that can cause these condition, especially in palpation as well as in manual mobilization, tenderness is usually absent if the pain is referred pain. That means if the pain is coming from the ligaments or muscle of the lower pelvic or the lower pelvic structure, or if the cause of coccygodynia is neurological in origin, then in these condition palpation and manual mobilization of the coccyx is not tender. Okay, and there is another special test, that is Valsalva test. Usually it is positive if the coccygodynia is secondary to the disorder of the neural structure. So by this basically it means that if the coccygodynia is secondary to the or disc prolapse, mainly L5S1 disc prolapse, or if the other neurological structure involvement such as schwannomas or neurinomas, or if there is there is arachnoid cyst, or if there is other neurological diseases in the lower part of the pelvis, then in these conditions Valsalva test is usually positive and tenderness is usually absent. So coming to the investigation, the first investigation that we have to send is the X-ray of pelvis. Usually AP and lateral view is seen. The more important view is lateral view, since the majority of cases usually it is followed by trauma. So it is it is ideally we should always check the status of the coccyx. What is the condition of the coccyx following the fall injury and onset of pain. We can do another test, that is dynamic lateral X-ray of pelvis. Can also be seen, where the patient X-ray is taken in standing position and another repeat X-ray is taken in sitting position. In this position we can see the change of the angle of the coccyx in sitting and in standing position. So in case of hypermobile coccyx, the angulation can be very high. So normally the angle change of angle is in sitting and in standing position is 2 degree to 25 degree. That is a normal change of the angle. but in hypermobile sacrococcygeal ligament, this angle can be more than 25 degree. And if the patient gives history of rheumatism, you always have to go for the blood test for rheumatism, that is complete blood count, ESR, CRP, anti-CCP, RA factor, and uric acid can be seen if they give history of rheumatism of them, of the family or of the patient. And sometimes in rare cases MRI might be required. So MRI is generally not required, but in some kind of rare cases such as precoccygeal epidermal inclusion cyst, or if the pathology is secondary to metastasis of from the intrapelvic or abdominal malignancy, then in these cases MRI can be helpful. So these are the simple test as well as the investigation usually done for the coccygodynia. So this is the X-ray picture of the various type of X-ray picture that you may see. So in this first picture with the white arrow basically denote there is a small fracture and slight subluxation of the sacrococcygeal joint. In the second picture, you can nicely see the sacrococcygeal joint is dislocated, and the coccyx is displaced anteriorly. And in the third picture, you can see a small bony spicule in the posterior aspect. So all these three conditions can be painful. So fracture with dislocation, fracture with subluxation, fracture with dislocation following acute fall or trauma, or sometimes it can be due to repeated sitting position or repeated micro trauma, especially if the patient is having small spicule of bone in the lowermost part of the coccyx. So these are the X-ray, typical X-ray picture that you might find with patient with coccygodynia. So another that I have mentioned, we can do dynamic X-ray of the coccyx. Here, as you can see in the picture, here two X-rays are taken, one in standing film and see the angulation of the coccyx. Another is repeat X-ray is taken in the lateral view in the sitting position. So you can see the change of angle of the coccyx. So here, this is the angle. So initial angle at standing, standing the straight one, and in sitting you see the displacement or the movement of the coccyx. So normally this range is 2 to 25 degree, and if it's more, then the diagnosis of hypermobile sacrococcygeal ligament it is called hypermobile sacrococcygeal ligament, and this can be also source of pain. And third, this is the MRI picture where you can see precoccygeal epidermal inclusion cyst. You can see this white, this is the dye taken by the cyst. So it is just in front of the lower part of the sacrum and the coccyx. So this can be sometimes be the cause of pain, and it is a rare cause of pain which can mimic coccygodynia. Okay, and normally if you go to the differential diagnosis, so there are three type of differential diagnosis. In case of nociceptive type of pain, so Levator-Ani syndrome can be there. So in this Levator-Ani syndrome, it is mainly secondary to the musculature of the pelvis. And here the interesting fact is that there will be no pain during mobilization, though the patient can there can be pain during there can be pain. Patient usually points out at the area of the upper part of the anal canal or lower part of the tailbone, but when examining there will be no tenderness or no pain during mobilization. So other nociceptive differential diagnosis is arthritis of the sacrococcygeal joint, osteomyelitis, avascular necrosis, chondroma, or precoccygeal cyst are all the differential diagnosis of the coccygodynia. So another is neuropathic in origin. So first thing we have to rule out is disc herniation. So L5S1 disc herniation can also cause pain in that area, or S2 compression can also produce area in similar pain in that area. So the disc herniation has to be ruled out. Another is rare causes are neural tumors. So in neural tumors, the typical finding during palpation and the mobility of the coccyx, the pain during mobility of coccyx will be usually absent. And the neural tumor that can cause coccygodynia are schwannomas or neurinomas, or arachnoid cyst of cauda equina, or sacrococcygeal meningeal cyst are all neuropathic cause of the coccygodynia. tailbone pain. And there can also be sometimes referred visceral pain, such as pain arising from rectum, sigmoid colon, or other pelvic structures, or urogenital structure, or sometimes there can be metastasis of the lower pelvic or lower abdominal pathologies, and that can be a cause of pain. And infection can also be a pain in referred pain in the differential diagnosis of tailbone pain. So regarding treatment modalities, usually it is there are two type of treatment modalities. One is conservative management, and another is intervention management. Normally, if the onset of pain is acute or subacute, that is within 1.5 month or 2 month, we usually go for non-steroidal anti-inflammatory drugs. Or we also advise the patient to adapt the sitting position as shown in the video. Their coccygodynia pillows are available in the market, and patient can sit on the pillow. So basically there will be a hole in the pillow, and patient will put the coccyx just over the at the hole, so that the pressure effect while sitting will be absent and the pain will be relieved. So that can be done. And physiotherapy, especially manual mobilization of coccyx, has shown to give an excellent result in the initial stages. So if the patient comes with tailbone pain, always, if the and mode of injury is acute, or duration of problem is acute or subacute, always go for the conservative management with oral pharmacotherapy, mainly NSAIDs, followed by change in the sitting position and physiotherapy. So if the conservative management is not giving you a good result, or patient would not want to wait for a longer period for the conservative management, then you can, or if the pain score is too high, so then in these conditions you can jump to the intervention. So according to the World Institute of Pain, the maximum benefit is with local infiltration of the coccyx with injection of local anesthesia and steroid. This has given the maximum result, and the evidence is 2C plus. Okay. And they have also suggested to add, after injection of local and steroid around the coccyx, they have also advised to go for manual manipulation of the coccyx, mainly the manual manipulation of the sacrococcygeal joint as well as first intercoccygeal joint. So this has given the very good result if you are going for the injection therapy. If this is not helping, then you can go for the diagnostic ganglion impart block. And if the ganglion impart block diagnostic test is positive, then you can also go for the radio frequency, depending upon the period of pain relief. And sometimes you can also, if that is also not helping, then sometimes you can go for the caudal epidural steroid injection. But the evidence for ganglion impart block as well as radio frequency and caudal epidural is evidence level is zero. So the maximum evidence level they have given is local infiltration of the coccyx, and coccyx mainly with local and steroid, either lignocaine or bupivacaine. And sometimes if these conditions are not helping, then we can go for pulse radio frequency of ventral MI of S34. And rarely, in some cases, surgical excision has been also advocated in patient with coccygodynia, chronic coccygodynia, which is not relieved with conservative management and intervention. Okay, so this is a coccygodynia pillow that you can easily get in the medical store, and you can see here the patient is resting over the on the this pillow, and you can easily see the coccyx part is just at the hole, so that pressure effect will not be there. Another, in right side of the picture, you can see augmentation of sitting position, means when the patient sits with leaning at the back, so this will cause pain as there will be pressure on the coccyx. So we can also advise those patients with coccygodynia to lean in front while sitting, so this can also relieve pain. So this is basically adaptation of the sitting position, which is initially advocated to the patient. So if this maneuver is not helping, then we can go for the intervention treatment. So in this picture you can see the local and steroid is given around the coccyx bone. So that is the main, according to the World Institute of Pain, this is the first treatment that you should be doing, and it has a evidence level of 2C plus. So along with this, if you send the patient for manual manipulation of coccyx, that has the best result. If this is not helping, then you can shift to the, this is the picture here, you can see the ganglion impar block being given. So this is the fluoroscopic picture of the lateral view. Here you can see the needle through the sacrococcygeal joint, and just the needle tip is just in front of the anterior sacral plate, and you can see a beautiful distribution of the dye. So this is basically an area of ganglion impar, and if you see this dye, you can give either local with steroid, or you can also go for alcohol neurolysis, chemical neurolysis, to block the ganglion impar. So, and if the ganglion impar is giving you result, but it is for a short period of time, then you can even go for the radio frequency ablation of the ganglion impar by putting two needles. So it is advocated that one needle should be put through the sacrococcygeal joint, and another needle should be inserted or can be inserted through the first intercoccygeal joint. So with this, we can also create a bipolar lesion around the ganglion impar that can also give you a good pain relief. So if these two things are not helping, then you can shift to the caudal epidural. So this is the fluoroscopic picture of the caudal epidural steroid dye distribution in the caudal epidural. Here you can, this is the lateral view. Here you can see the needle just into the sacral canal, and you can also see the in AP view this beautiful Christmas tree appearance of the dye. So these are the various interventions that you can do in patient with coccygodynia, which is not relieving with conservative management. So there is a treatment algorithm given by the World Institute of Pain. So if the patient with coccygodynia comes, first is conservative management depending upon the duration of pain. So if it's acute or subacute, if it gives unsatisfactory result, then we can jump to intervention. So first intervention that is advocated is local injection of local anesthetic and steroid, corticosteroid. If this is not giving you good result or unsatisfactory result, then you can consider giving diagnostic ganglion impar block followed by chemical neurolysis or radiofrequency ablation, or you can also go for the caudal epidural steroid injection if ganglion impar block is not helping or not relieving the pain. Okay, so few complications are there during ganglion impar block. Some complications are very common, such as bleeding, infection is very common. So sometimes there can be increase in pain, but the another dreadful complication that we should be aware of is injury to the intrapelvic structure. So especially injury to the rectum can happen when you are going for ganglion impar block or radiofrequency ablation of the ganglion impar, and because normal distance of the coccyx and rectum is usually it is up from 1 millimeter to 34 millimeters. So this is the safety margin that we have. So always use dye and confirm the placement of the needle, and once the needle is just in front of the anterior sacral plate, you have to stop more further advancement of needle and give dye. Okay, so that is the precaution that you can take to avoid the injury to the especially pelvic structure, especially rectum. Okay, so thank you very much. So we'll do the discussion after the each section, or shall I continue to other slide and finally we'll go for the discussion? What do you say?
You can go ahead with the all the cases, and then you can start the discussion series.
Okay, sir. Okay. So this is the one case. Now, and I'll be presenting a case of piriformis syndrome. A male patient came to the clinic with pain in the right buttock. So let's first go for the video. And this video is unfortunately bit long. Okay, so please bear with me. Okay. So this is
नमस्ते भाइको नाम के पर्यो होला आशिष खड्का कति वर्ष हो
is the sound audible, sir?
कहाँबाट आयो सरलाई के समस्या हो
Yes, it is audible. Audible.
समस्या भयो
So young boy came to the clinic with buttock pain.
चाकमा दुख्छ यो दुखाइ कति भयो तिमीलाई भएको चाहिँ
2 महिना 3 महिना जति
2-3 महिना भयो 2-3 महिना भयो यो दुखाइको मलाई एकचोटि बयान गर त कसरी सुरु भयो तिमीलाई
त्यतिकै अब म आइटी कम्पनीमा काम गर्छु त्यसमा 24 घण्टा बसिराख्नुपर्छ नि त्यही भएर यो बस्दाखेरि धेरै दुख्छ
बस्दाखेरि धेरै दुख्छ।
81 भयो
81 भयो र बिस्तारै बढ्दैछ यो
बिस्तारै
बढ्दैछ।
कहिले बढ्छ झट्टै कहिले कम हुन्छ
बढ्ने कहिले बढ्छ त यो
बसिरहेको हुन्छ धेरै बढ्छ जस्तै अहिले
बस्दाखेरि दुख्छ। र के गर्यो भने आराम हुन्छ त तिमीलाई
यो हिँड्यो भने सुत्यो भने साइक्लिङहरू चाहिँ गर्न अलि मिल्दैन पहिला धेरै गर्थेँ अहिले चाहिँ अलिक गर्न कम गरेको छु
जस्तै तिमीलाई 5 वटा पोजिसन भन्छु है त म एउटा बस्ने भयो एउटा बसेर उठ्ने भयो एउटा उठिराख्ने भयो एउटा हिँड्ने भयो अर्को सुत्ने यी मध्येमा तिमीलाई गाह्रो केमा हुन्छ र सजिलो केमा हुन्छ
बसिराख्यो भने चाहिँ लास्टै गाह्रो हुन्छ
ओके
र हिँड्यो सुत्यो भने चाहिँ अलिक आरामै
बसेर उठ्दाखेरि
बसेर उठ्दाखेरि पनि
त्यस्तो केही छैन उठ्दाखेरि
उठ्दाखेरि
केही पनि छैन सो तिमीलाई चाहिँ समस्या बस्यो कुर्सीमा बस्यो भने दाहिने साइडको तल चाक दुखेर आउँछ तर उठ्यो हिँड्यो सुत्यो भने तिमीलाई केही पनि अप्ठ्यारो छैन ओके र यो दुखाइ चाहिँ कति छ जस्तै 0 भनेको दुख्दै नदुख्ने 10 भनेको एकदमै धेरै दुख्ने जस्तै हस्पिटलमा गएर सुई नै लाउनु पर्ने दुखाइ भयो भने तिमीले यो दुखाइलाई कति नम्बर दिन्छौ 0 देखि 10 सम्म
कहिले चाहिँ 7-8 पुग्छ कहिले चाहिँ 3-4 त्यस्तो हुन्छ
कहिले 7-8 हुन्छ र
अब धेरै बेर बसिराख्यो भने अब 12 आवर्स बस्नुहोस् त्यतिकै बसिराख्यो भने चाहिँ
र के गर्यो भने तिमीलाई आराम हुन्छ जस्तै तिमीले भन्यौ 2-3 महिनादेखि यो दुखाइ छ तिमीले डेफिनेटली केही न केही त गर्यो होला दुखाइ त्यो गर्नलाई तिमीलाई के गर्यो भने चाहिँ दुखाइ कम भए जस्तो हुन्छ कम हुन्छ कस्तो खालको मेडिसिन खाएर कम हुन्छ पेनकिलर जस्तै फ्लेक्जन ग्लुसेटहरू खायो भने कम हुन्छ र अरू कुनै जस्तै तिम्रो तातोले सेक्यो भने कम हुन्छ कि
तातोले त मलम लगाएर तातोले सेकेपछि
आराम
अलिकति
हुन्छ
कम अलिकति कम भएको जस्तो हुन्छ नभए त्यसरी
जस्ताको त्यसो छ तिमी पहिला के लडेको त्यस्तो केही थियो चाकले बजारेको त्यस्तो केही छैन छैन र घरमा कसैलाई बाथ रोग त्यस्तो केही छ अनि यो दुखाइ जुन चाहिँ तिमीले भन्यौ यो कहाँ छ मलाई चाहिँ देखाउ त त्यहाँबाट चाहिँ यसो सरेको छ तल आउँछ यतातिर खुट्टामा तल आछ
सुरुको 1 महिना जति चाहिँ सरेको थिएन पछि फेरि बस्दै गयो अनि त्यसपछि चाहिँ यो अलिक टिकेर भन्दा तलसम्म यहाँसम्म चाहिँ
सो यो दुखाइ चाहिँ सरेर यहाँ अलिकतिसम्म आछ
तलसम्म आएको छ
यो बस्दाखेरि नै दुख्छ
बस्दाखेरि बस्दा दुख्छ
ओके र म
अनि साथीहरू अब यो मैले साथीहरूसँग एडभाइस लिँदाखेरि चाहिँ अब यो नसा च्यापेको कतिले अलिकति मन डरायो
किन नसा च्यापेको भन्यो त
अब यो दुख्यो यो नसा च्यापेको सिन्ड्रोम हो यस्तो भन्ने सुनेको थिएँ त्यही भएर यसोलाई गर्नुपर्छ भन्ने कतिले अलि अप्ठ्यारो लागेर देखाउन आएको यहाँ पेन फिजिसियनमा
सो तिमीलाई चाहिँ यो खुट्टाको तल सऱ्यो भएर डर लाग्यो नसा च्याप्यो भनेर र एमआरआई गर्नुपर्छ कि भनेर आएको ए ल ल ल र तिमी ल ठिकै छ तिमी एकचोटि यो खुट्टा यसमाथि राखेर बस्छ यसरी एकछिन
So I'm doing a cross leg test,
बस्यो भने यो
provocative test.
यसरी बस्न साथै दुख्छ यही ठाउँमा दुखेर तल आउँछ एकचोटि म जान्छु है त ल आउनु भाइ यो ज्याकेट खोल्दै पनि हुन्छ
So now I'm doing clinical examination of the patient.
भर्खरको अगाडि केटालाई के भएछ है आमामै भएछ म जे जे गर्छु तिमीले पनि त्यही गर्ने है त
So I'm checking range of motion, forward bending.
छैन अब यसो गर त मेरो भाइ यसो गर त यसो गरेर दुख्छ छैन दुख्दैन अब यसो गर त दाहिनेतिर यसो देउरै
I'm checking the lateral rotation.
एकचोटि औँला उठाएर यसरी हिँड त अप्ठ्यारो छ के छैन कुर्कुचाली टेकेर मतिर आऊ
So I'm checking heel walking and toe walking. So all the test was negative in that patient. So now I'm checking the
So I'm doing inspection. So right in the inspection you can see his right leg is externally rotated. So that means that also give us clue that problem can be in piriformis. Okay. So this is in inspection. So basically I am inspecting from all sides, but as you can clearly see, so the leg of the patient is externally rotated in that side. So that means some kind of muscle problem, especially in piriformis syndrome, this can happen. Okay. So now I'm doing free burst test. यसो गरेर दुख्छ दुख्छ यो चलाउँदाखेरि दुख्छ दुख्दैन तर यो चलायो भने दुख्छ
So this is a Freeburg test, which is positive.
Okay, this is a Freeburg sign. So this is also one of the confirmatory sign of one of the signs for piriformis syndrome. Okay. So एकछिन हल्का छोडिदियो है म तिम्रो खुट्टा चलाउँछु के अप्ठ्यारो भएको छ छैन होइन
So I'm doing favor test.
यहाँ दुखेछ छैन यसो गर्दा दुख्छ दुख्यो कहाँ दुख्यो यहाँ
I'm doing a fear test.
के पर्स पनि लगाइरहेको छु है अस्ति पर्स राख्नु हुँदैन कहाँ छ निकाल
So he has kept one purse there.
पर्स कहिले पनि नराख्ने गोजीमा है यो त समस्या गर्छ यसले है त फेरि म एकचोटि गर्छु है त
So favor.
This is a favor test, which is negative. So now I am doing a fear test. So flexion, adduction, internal rotation. It is यहाँ दुख्छ oh no, so he is causing pain for you. यो भयो नि त ल अर्को चाहिँ यसो गरौँ त यसो गरेर यो खुट्टा यसो माथि उठाउँ यसो गरेर नि दुख्छ यसो गरेर दुख्छ
So this is a heel contralateral knee test.
This is a heel knee contralateral knee test, which is also positive. Okay. So म बिस्तारै खुट्टा उचाल्छु है तिमीलाई के दुख्यो भने भन यो खुट्टा उचाल्दाखेरि के अप्ठ्यारो छ
So I'm doing straight leg rising test.
जाँच गर्छु है त यसो गर्दाखेरि के अप्ठ्यारो छ
So here you see there is no pain.
है यो चलाउँदाखेरि दुखेको छैन हैन मैले यो खुट्टा उचाल्दाखेरि दुखेको छ छैन मैले यो खुट्टा उचाल्दाखेरि दुखेको छ
So
अहिले दुखेको छैन नि
SLR was negative.
मैले यहाँ छामेको र यहाँ छामेको बराबर छ जस्तै मैले दुई ठाउँमा छामेको छु चाल बराबर छ दुवैतिर बराबर छ यहाँ पनि चाल बराबर छ
I'm checking the sensation of
यो
the
ठाउँमा
patient
कस्तो छ बराबर छ
at L4 and L5.
तान त तान 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 बेसरी तान
So I'm checking the motor function of L5
तिर खेल त खेल
and S1.
के अप्ठ्यारो छ छैन एकछिन है थोडा काम थियो मेरो
So now I'm checking the
You
reflexes.
can still see leg is externally elevated. यहाँ कबुदी लाग्छ हैन यहाँ कबुदी लाग्छ so that is there.
So checking the reflexes.
Normal sensory and normal motor function. SLR is also negative. So only positive finding I could find was externally elevated leg is. Free burst test is positive. So still he is having pain. Fear test is positive. Heel to contralateral knee test is positive. Okay. So there is another test known as Betty test. Okay. I want to do Betty test. This can also be positive. So with actually further. So यसरी खुट्टा त्यो गर यसरी खुट्टा गर म यो खुट्टा अलिक उचाल्छु यतिकै उचालेर राख्न सक्छ सक्दैन हेरौँ है दुख्यो कहाँ दुख्यो so he is having this is a Betty test which is also positive okay ल एकचोटि घोप्टो पर त so म हातले देखाउ त तिम्रो औँलाले देखाउ त कहाँ दुख्ने हो यहीँनिर हो ल म एकचोटि छामेर हेर्छु है त
So I'm palpating the area of tenderness.
छैन हैन
Now at the paramedian region of the lumbar spine.
So I'm palpating the midline. I'm palpating the paramedian region. He's having no pain. I'm palpating the SI joints. Yeah, duksa? Duksa. So now I'm palpating piriformis. Duksa? Okay. Yeah? Oh, so he's having. Okay, he's having tenderness in the piriformis. So most of the tenderness is positive in piriformis. Now the last test I want to do is known as
So I'm doing pace test now. This you need not do all the tests, but I'm just showing you that these are the all tests that can be done.
यता थिच्छु तिमीले चाहिँ यसता थिच है त तिमीलाई दुख्यो दुख्छ कि दुख्दैन हेर्नु छ ल जबरजस्ती खुट्टा यता पठाउ त
So
यता बाहिर ल्याउ त बाहिर ल्याउ दुखेछ यहाँ चाकमा दुखेछ होला दुखेछ छैन दुखेछ अलि कहाँनिर दुखेछ यसो गर्दा
So this pace test is also positive.
This is a base test which is also positive. मेरो विचारमा चाहिँ कस्तो छ नि भाइ तिम्रो यो चाकमा चाहिँ तिम्रो नसा थिचेको जस्तो लाग्दैन मलाई कहिलेकाहीँ नसा थिच्दाखेरि पनि यो दुखाइ अलिअलि यहाँ तलसम्म त आउँछ तर त्यही भएर तिमी डर लाग्यो तर मेरो विचारमा चाहिँ चाकमा एउटा मासु हुन्छ कि त्यो मासु चाहिँ दुईतिर जुङ्गा जस्तो मासु यसरी छेउमा हुन्छ त्यो मासु चाहिँ लामो समयसम्म बस्ने मान्छेहरू या यसरी यो पर्स पछाडिमा राख्नेहरूको चाहिँ दुख्छ कहिलेकाहीँ रिसाउँछ त्यो रिसाउँदाखेरि चाहिँ यस्तै चाकमा दुख्छ र यो तलसम्म आउँछ यो दुखाइ बुझेनौ मलाई चाहिँ त्यसलाई चाहिँ यसलाई चाहिँ पिरिफर्मिस सिन्ड्रोम भन्छ मेरो विचारमा पिरिफर्मिस पेन या पिरिफर्मिस सिन्ड्रोम हो डराउनु पर्दैन र सुरुमा चाहिँ म तिमीलाई एकचोटि दुखाइ कम हुने औषधि तातोले तिमीले भनिहाल्यौ तातोले सेक्यो भने कम हुन्छ होइन र तिमीलाई मसल रिल्याक्सेन्टहरू दिन्छु केही गरी हेर्छु र त्यसले पनि भएन भने चाहिँ यो भिडियो एक्सरेको माध्यमबाट म तिमीलाई चाहिँ यो चाखमा जुन मासु रिसाएको छु त्यसलाई चाहिँ हामीले घोचेर त्यसलाई नरम बनाउन मिल्छ र अहिले म त्यो मासु रिसाएको छ कि छैन भनेर म एकचोटि हेर्न चाहन्छु र यो भिडियो एक्सरेले देखिन्छ त्यो है तिमीले यदि अनुमति दिन्छौ है म तिम्रो यो भिडियो एक्सरेले हेर्न मिल्छ यो चाहिँ एक्सरेमा देखिँदैन है एमआरआईमा कहिलेकाहीँ देखिन सक्छ अब एमआरआई त महँगो जाँच भयो त्यही भएर हामीले सस्तो मिठो जाँच पहिला म युएसबाट हेर्न चाहन्छु र यसमा मैले तिम्रो सुतेर म खुट्टा अलिक चलाउँछु र भिडियो एक्सरे गर्छु कहिलेकाहीँ चाहिँ त्यसमा मोटो भएको देखिन सक्छ र तिमीलाई त्यहाँ जुन चाहिँ मैले त्यो यो मिसिनले राख्न साथै त्यो ठाउँमा पनि दुख्न चाहिँ सक्छ त्यही भएर म एकचोटि चेक गर्न चाहन्छु है
I have asked permission to scan the piriformis of the patient.
तिम्रो अलिक तल सार्दैछु है अलिकति अप्ठ्यारो नमान है त यतिसम्म कपडा तल सार्दैछु
Luckily, patient agreed.
दुख्ने कहाँ हो एकचोटि हातले देखाउ त यहीँनिर हो यो यहीँनिर हो दुख्छ नि होइन सो म एकचोटि भिडियो एक्सरे गरेर हेर्न चाहन्छु ल
So the beauty of ultrasound is we can show the pathology to the patient right on the table, as well as confirm our diagnosis also. So I'm using a curvilinear probe, and I'm setting the depth at around 6 centimeter, 5 to 6 centimeter.
अलिक चिसो हुन्छ है भाइ म अलिकति हेर्दैछु
So here you can see I've started the examination from.
your superior iliac spine
So you can.
coming down
So I'm scanning, trying to get the piriformis.
यसो गरेर त एक्चुअली यो खुट्टा एउटा यसो राख त यतिकै राख ल खुट्टा है म खुट्टा अलिक चलाउँछु ल
So you may have noticed the knee is flexed, so we can move the leg.
this muscle so like mustache like muscle this is the ischial spine you can see
So here you can see if I move the leg,
मैले यो राख्दाखेरि दुखेको छ so this is a piriformis very nice to see
you can see
the
piriformis is moving.
you can see yeah यता हेर त बाबु
So I'm showing the problem to the patient.
यो जुङ्गा जस्तो मासु हो नि यही हो हेर त यहाँबाट यसरी गइरहेछ र यसले चाहिँ यो खुट्टालाई चाहिँ यसो चाहिँ गर्छ देख्यौ तिमीले यो जुङ्गा जस्तो मासु चलेको हो यो
can
मासु चलेको देखाएको छौ नि यो मासु चाहिँ तिम्रो मोटो भएर बसिरहेको छ रिसाएर बसिरहेछ
Thickened piriformis.
अहिले मेरो विचारमा त दुखेको मासु यही हो सो तिमीलाई अहिले म अहिले एकचोटि यताको पनि हेर्छु होइन यताको पनि एकचोटि हेर्न चाहन्छु
So I'm comparing with the other side.
यसो गरौँ त म एकचोटि यताको पनि हेर्छु यता पनि त्यस्तै मासु हुन्छ देख्यौ तिमीले यो मासु अलिक पातलो छ होइन यो मासु त तिमीले
So you can see this thickness of this is less.
यो मासु नाप्यो भने यहाँबाट यसरी नाप्नु पर्छ होइन
I'm measuring the thickness of the piriformis.
कम छ यो मासु होइन तर मैले यतापट्टिको मासु नाप्यो भने चाहिँ तिमीले हेर त बिस्तारै त्यहाँ राख्न साथै यही ठाउँमा दुख्नु पर्ने हो
So you can see
मोटो भएर बसिरहेको
thickened and hypoechoic piriformis.
नाप हो है त यो कति रहेछ यताको
So I'm measuring the piriformis thickness.
हेर त यो मोटो भएर झन्डै 1.77 सेन्टिमिटरको मोटो भएर बसिरहेको छ सो यो मासु रिसाएको हो है यसलाई चाहिँ पिरिफर्मिस सिन्ड्रोम भन्छ यसरी हेर त ठ्याक्कै देख्यौ नि कति मोटो भएर मासु रिसाइरहेछ र यसरी चलायो भने यो मासु पनि चल्छ हेर देख्यौ नि चलेको
So you can see
तिमीलाई यसो गर्दा
movement of piriformis as I externally rotate the leg.
ओके सो अहिलेलाई चाहिँ म तिमीलाई के गर्छु त अहिले म तिमीलाई दुखाइ कम हुने औषधि मसल रिल्याक्स हुने औषधि र फिजियोथेरापी गराउँछु है फिजियोथेरापीमा पठाउँछु यदि त्यो फिजियोथेरापीमा गएर पनि दुखाइ कम हुने औषधिले पनि तिमीलाई भएन भने अहिलेलाई चाहिँ औषधि दुखाइ कम हुने मसल रिल्याक्स हुने औषधि मुभ लाउने या डिएफओ जेल लाउने र तातोले सेक्ने र म तपाईँलाई फिजियोथेरापीका पठाउँछु र फिजियोथेरापीले यो खुट्टालाई माथि तान्ने होइन र एकचोटि सुत्ता त म तिमीलाई 2-4 वटा देखाइदिन्छु है जस्तै यो भयो होइन यो खुट्टालाई चाहिँ यो खुट्टालाई यसो गरेर आफूतिर तान्ने यतातिर
So I'm basically teaching few physiotherapy steps.
होइन फेरि यसो लगेर यो दुखाएर यताको यो चाकलाई चाहिँ यतातिर तान्ने यो गऱ्यो यो मसल रिल्याक्स हुन्छ त्यो एक्सर्साइज गर्नु पर्यो तिमीले होइन र म फिजियोथेरापीका पनि पठाउँछु उसले पनि 2-4 वटा नयाँ एक्सर्साइज सिकाउँछ त्यो एक्सर्साइजले भएन भने म यसरी नै भिडियो एक्सर्साइज हेरेर जुन मासु रिसार्छ त्यो मासुलाई 10-15 चोटि म सियोले घोचिदिन्छु त्यो गर्यो भने चाहिँ तिमीलाई आराम हुन्छ तर जहिले पनि सियो लाउनुभन्दा अगाडि तिमीलाई पनि मन पर्दैन चाकमा घोचेको होइन त्यो भएर सुरुमा चाहिँ औषधि फिजियोथेरापी र लाइफस्टाइल चेन्ज भन्नाले त्यो पर्सहरू पछाडि नराख्ने अगाडि राख्ने लामो समयसम्म नबस्ने है र म कुर्सीमा बस्दाखेरि कुर्सीमै बसेर पनि यो एक्सर्साइज गर्न मिल्छ म त्यो एउटा सिकाइदिन्छु है त आउँछ तिमीले के गर्नु पर्यो कुर्सीमा तिमीलाई यो चाक दुखेको हो नि त यहाँ होइन यो चाक दुखेको यो खुट्टा यसरी राख्ने र यसरी थिच्ने यो सिधा राख्ने या तिमी अगाडि 30 डिग्री यसरी टिक्ने 30 सेकेन्ड बस्ने र 30 सेकेन्ड आराम गर्ने या 30 सेकेन्ड बस्ने 30 सेकेन्ड आराम यो गरे पनि भयो या यसलाई यसरी ठेले पनि भयो 10 सेकेन्ड ठेल्ने 10 सेकेन्ड आराम गर्ने 10 सेकेन्ड ठेल्ने 10 सेकेन्ड आराम गर्ने यो गर तिमी 1 महिना जति औषधि खाऊ मुह लाएर तातोले सेक त्यसले पनि भएन भने म सुई लाएर यसलाई खुवाउँछु है त डराउनु पर्दैन ल है त मेरो भाइ ल टेक केयर
So just now there was it is a case of piriformis syndrome. I'm sorry for the long
Series, I have to leave because of some urgent need. So what you can do is we can do the discussion of these two cases. After that, I'll be leaving and you can continue with the last case.
Yes, sir. Yes, sir. This is the last case, sir. I'm just discussing the PowerPoint of what might be the condition.
Okay. Go ahead.
So this is the. Can you see my slide, sir? Full view.
Yes, we can.
So this the video that you saw is of the piriformis syndrome. It's quite common in pain clinic. So regarding the summary of case, a 21 years young male came to my clinic who is an IT profession, who sits in a chair for a longer duration of time. So he had a right buttock pain for last 2-3 months duration, and the onset of pain was gradual. Nature of pain was deep aching in nature, and occasionally since last month the pain has radiated to the posterior thigh, not beyond the knee, and numerical rating score of pain was 7 to 8 when the pain was extreme, and lower when the pain was less, the pain score was 2 to 3, so it was a bearable pain. So normally the aggravating factor that the patient says that sitting on a chair or cycling or sitting in a cross-legged position usually aggravated his pain, and other position like standing, walking, or lying supine relieve the pain. Similarly, non-steroidal anti-inflammatory drug and application of it also relieve the pain in this particular patient. And he gives no history of morning stiffness and no history of inflammatory arthropathy in the family, and he also gives no history of acute trauma basically before the onset of pain. So on examination, on back examination, basically range of motion was normal, so flexion, extension, and lateral rotation was all normal. Heel walking and toe walking were also normal. In inspection, basically which was done in supine position, you could see the affected leg was externally rotated, which is one of the key finding in case of piriformis patient. And in palpation, you can also you could appreciate tenderness over the buttock, mainly over the right piriformis. Freeburg's test was positive. fear test was also positive, heel to contralateral knee test was also positive, and Betty as well as pace tests were all positive. So so these are the few tests that you have to bear in mind. So Freebird test is one of the oldest tests which has been with us for more than 100 years, and still it is the first test that has to be done. And nowadays modified Freebird test is also there. I'll be showing you the picture of that. So and here it is mandatory to check the neurological status of the patient, check the straight leg rising test. Sometimes a sciatica can be a problem, which can be secondary to impingement of L5S1 disc prolapse, which can also mimic buttock pain and pain radiating to the thigh and leg. And always check the other neurological status such as sensory function, motor action of the lower limb, as well as reflexes of the patient to rule out disc prolapse. So the examination that we did was ultrasound examination. Previously, the before the incorporation of ultrasound in pain practice, the diagnosis was usually clinical. X-ray usually is negative in these cases. Sometimes MRI we can send patient with for MRI, but normally diagnosis was clinical. But after incorporation of ultrasound in pain practice, we can easily see the ultrasound you just saw. We can convince the patient, see the problem right in front of the patient, and get a good diagnosis. In this patient, probe tenderness was there over the right buttock, and you can also appreciate the piriformis of the right side was thickened and hypoechoic. So this was the ultrasound finding in this patient. So normally, as the patient duration of pain was just 2 to 3 months, I have opted for conservative management. So I've started with non-steroidal anti-inflammatory drug with muscle relaxant. I would go for baclofen for a week or two, and then also I've advised the patient to go for to put some non-steroidal anti-inflammatory gel and apply heat. As in history, he said that application of heat gave him a good pain relief. And physiotherapy is one of the most important thing in piriformis syndrome, which you should not forget. So I have opted this conservative management, and I have told the patient that if the conservative management fails, or if it's inadequate, we'd go for the intervention management. That is, I've told them that I will be doing trigger point injection of the piriformis under the guidance of ultrasound. Okay. So piriformis syndrome. So if you see the piriformis muscle, it is basically a muscle which causes lateral rotation of the hip, and it is one of the most important muscle stabilization muscle for the hip joint. And the origin of this piriformis muscle is from the pelvic surface or ventral surface of the sacrum, S2, 3, 4, and then it emerges out from the greater this sciatic foramen, and it is inserted at the superior border of the greater trochanter of the femur. So the contraction of the piriformis causes external lateral rotation of the hip joint. So in those patients with piriformis syndrome, you can see in inspection that the leg will be externally rotated. Okay. Coming to the blood supply, piriformis is supplied by superior and inferior gluteal artery, as well as internal pudendal artery, as well as lateral sacral arteries. And coming to nerve supply, so initially it was thought that piriformis was only supplied by nerve to piriformis with root value S1 to S2, but nowadays recent studies have suggested that piriformis is not supplied. Usually it is supplied by 2 or 3 nerves instead of just one nerve, and they have found out that with cadaveric studies, they have found out that 80% of the innervation is by 2 to 3 nerves, and among that 70% is from superior gluteal nerve, and 85% of time it comes from the branches that comes from the S1 ventral ramus, 70% it comes from S2 ventral ramus, and in 5% of cases branches also comes from inferior gluteal nerve and L5 ventral rami. So the main nerve innervating piriformis is basically superior gluteal nerve, ventral rami of S1 and S2. So initially it was thought only one nerve innervates, but nowadays that is the thing of the past. Nowadays usually supplied by 2 to 3 nerves. Okay. So coming to the action of piriformis, it causes lateral rotation as well as abduction of the thigh at the level of hip joint. So this is the schematic diagram of the piriformis. You can see piriformis originates from the ventral surface or the but the pelvic surface of the sacrum S23, and it is like mustache, like two muscle will come from either side, and you can see it is attached to the superior aspect of the greater trochanter of the femur, and you can also easily see the sciatic nerve just below the piriformis, as sciatic nerve emerges out from the pelvic structure and it becomes extra pelvic. In the picture, the right side of the picture, you can also see piriformis. Below the piriformis, you can see sciatic nerve, and above the piriformis will be the gluteus maximus muscle. So in ultrasound, you always scan from the posterior superior iliac spine, where you can appreciate gluteus maximus, gluteus medius, and gluteus minimus, and you just bring your prop downwards and more caudally and laterally, then you can see nice piriformis. Okay, so there can be various anatomical variation of sciatic nerve. It is not that the sciatic nerve is always below the piriformis. Yes, it is below the piriformis, is piriformis in 90% of the cases. So there is one classification given by Beaton and Son. It is an old classification, but still it holds its place till now. So they have classified sciatic nerve in 6 different categories, depending upon how it emerges from the greater sciatic foramen and the piriformis. A type is the most common. So here you can see in 90% of the cases, sciatic nerve comes out below the piriformis. And in type B, it is slightly different. It is present in 7.1% of the population. Here, sciatic nerve divides into common peroneal nerve and tibial nerve. And then common peroneal nerve will pierce the piriformis and come down, and the tibial nerve will come below the piriformis. So that is the type B. And in type C, what happens is it is present in 2% of the cases. Here, the sciatic nerve divides into two, and after division, it incorporates or it wraps around the piriformis from above and below. Then again it reunites and continue downwards as a single sciatic nerve. So this is the third variation. And in fourth variation, the sciatic nerve pierces the piriformis and it comes down. So this is present in about 1% of the cases population. And in types E, it is also present in 1% of the population. Here the sciatic nerve divides into common peroneal and tibial. The common peroneal nerve comes above the piriformis, and tibial nerve pierces the piriformis, and then these nerve again reunite and forms the single sciatic nerve and come down. And finally, the sciatic nerve sometimes can be above the piriformis as it emerges from the greater sciatic foramen and comes downward. So these anatomical variation should be in your mind while doing ultrasound examination of the piriformis and sciatic nerve. Okay. And most common causes of piriformis syndrome is most common cause is muscle strain. Okay, as you can you appreciated in this video also, the patient was young patient who worked in IT profession. So he said that he has to sit in the chair for a longer period of time. So sitting in a chair for longer period of time, especially if the chair is hard surface chair, then that can be a causative factor for piriformis syndrome. Another is, if you have noticed, this patient was carrying a wallet in the posterior part of the buttocks. So sometimes this wallet can further increase your risk of developing piriformis syndrome. So we advise not to put the wallet in the posterior part of the pocket, keep it in the front side. So these are the common causes. And cycling also, he said that he used to do lots of cycling, but after piriformis getting, after buttock pain, the cycling has decreased. So these are all factors that can cause muscle strain, which can cause piriformis syndrome. And another common cause is gluteal trauma. So if there is any trauma to the gluteal region, that can also mimic or cause piriformis syndrome. Other less common causes are basically total hip arthroplasty, especially from the posterior approach, or intragluteal injection. We commonly see intragluteal injection. So this can also cause piriformis syndrome in few cases. cancer metastasis of the cancer or post-radiation myositis can also be a problem cause of piriformis. Leg length discrepancy can be a problem, and there has been reported cases of few cases case report of like side effect of statin causing piriformis syndrome, or hematoma or infection in the buttock region, or myositis causing piriformis syndrome. Abscess or Crohn's disease or endometriosis has also been associated with piriformis, and there has been few case report of these condition causing piriformis syndrome. But the most common cause is muscle strain, number one, and number two is gluteal trauma. So normally if you see the clinical presentation, patient typically presents with buttock pain. Sometimes this buttock pain can be alone, or it can be associated with radiating pain towards the thigh, to the below leg. So and normally this leg, the radiating pain is in the posterior aspect of the thigh, usually not extending below the knee joint. And another key point in history is pain is usually exacerbated or increased in sitting position, especially sitting in hard surfaces, like accountant or even doctors or IT profession. They have to sit for a longer period of time in a sitting position. So this can be a causative factor for piriformis syndrome. And any condition that increases the demand of piriformis, like leg crossing or climbing upstairs, can also be painful in piriformis syndrome. And sometimes there can be associated with piriformis pain can be associated with numbness and paresthesia along the distribution of sciatic nerve, because as you just saw, sciatic nerve is just below the piriformis. So when the piriformis gets angry and is contracted, so this can also cause pressure effect to the sciatic nerve, that can cause mimic radicular pain going down to the leg. So it is also known as pseudo-sciatica. So when there is sciatica, usually the problem is secondary to disc prolapse, mainly L5-S1 disc prolapse, causing impingement of S1 nerve root, which also supplies to the piriformis. So that is basically sciatica. But if there is no disc prolapse, and if the impingement is at the level of the piriformis muscle, then it is called pseudosciatica. Okay, and sometimes there can be gait disturbance. So normally patient will present with pain over the buttocks, and which is indicated by X mark. And so you can see the presence of piriformis muscle just below the X mark. Okay, and sometimes the pain can radiate downwards in the posterior aspect of the thigh to the leg also. Okay, in physical examination, in inspection, in majority of cases, you can see externally rotated affected leg. So in this picture also you saw, especially most probably he has a problem in the right side of the buttock, and his leg is externally really, rotated, right leg. So this is the typical finding in inspection. And in palpation, there will be tenderness over the piriformis or sciatic notch, which is also known as Lesigue sign. So when you ask the patient to show the area of pain, patient usually shows to the buttock, points the pain area over the buttock, and on palpation over that area, it is usually painful. And there are few provocative tests that I have shown in the video. These tests can be also positive. Mainly the Friedberg's test. So Friedberg's test is one of the oldest tests. It's almost 100 years it's been invented, and still now we routinely do Friedberg's test with any patient with buttock pain. And nowadays modified Friedberg's test is also there. So this modified Friedberg's test is usually done in prone position. So in prone position, what we do is we basically flex the knee joint and abduct the leg and externally rotate the leg. So this will produce pain. This same movement we do while doing ultrasound examination of the piriformis. So that is also modified Friedberg test we usually do during ultrasound examination of the piriformis, where we make the patient prone and put the probe over the piriformis and check the movement of the piriformis as we see the dynamic movement of the piriformis as we move the leg internally and internal and external rotation. Okay, so another test that can be positive is a fear test. Fear basically stands for flexion of the hip joint. adduction of the hip joint and leg, and internal rotation of the hip joint. So this can in this test patient can have pain over the buttock. And another is modified fear test is also there. In modified fear test, basically it is a combination of fear test with Lesage sign. Here we do flexion, adduction and internal rotation of the affected leg, and also we press the area of piriformis, so that will exacerbate the pain in case of modified fear test. And Betty test is also there, which you saw in the video. Betty test is basically a passive test for the piriformis, where we put the patient in lateral position with affected buttock in the upside, and then we ask the patient to flex the hip and the knee and abduct the leg. So if the and tell the patient to hold the leg in that position. So when they do this test, there can be pain in the piriformis region or buttock. Another is heel contralateral knee test is also there, which you just saw in the video. And another last test that you saw in the video was pace test. So pace test is an active test of piriformis, where we do this test in sitting position. We ask the patient to sit down, and then ask the patient to abduct the knee, and we apply the pressure against the knee. So when we do that, there when the patient abduct the leg, then there can be pain over the buttock, painful buttock. So but there is no having said that, there are lots of provocative tests and palpation and inspection. So these are the basically the tests that you have to follow in patient with. And don't ever fail to check the neurological status of the patient. Check the straight leg rising test, motor, sensory and reflexes has to be checked, because sometimes there can be sciatica can also mimic similar type of pain, where there is pain over the buttock and radiating pain downward to the thigh or even to the leg. Okay, so those tests has to be done. And there is no gold standard test for the single gold standard test for checking the piriformis muscle. Sometimes we can also give local anesthesia over the piriformis muscle under the guidance of ultrasound, and again redo the test. And if the problem is in the piriformis, so this all the tests, provocative test, can be negative and there can be pain relief. So that can be one of the tests that you can do for patient with piriformis syndrome. Okay, so this is the Freiberg's test and modified Freiberg's test. Here you can see the patient is in supine position. We basically internally rotate the externally. So normally, suppose this patient the leg is affected, then what the examiner is doing is holding with one hand knee joint, and with another hand he is basically internally rotating the leg. So this will produce similar pain in the buttock. So that is a Freiberg's test. Sorry. And this is another test is modified Freiberg's test. Here it is done in prone position. As you can see, patient's knee is 90-degree flexed, and the examiner is abducting and externally rotating the leg. So this will also produce pain. This same maneuver we usually do while checking the integrity of piriformis in while using ultrasound. So both of these tests are routinely done in clinical practice. Other provocative tests are like pace test, as you have already seen. Patient lying in the lateral position with affected buttock upwards, and we ask the patient to abduct the leg and hold it in this position. So that will cause pain over the piriformis area or buttock area. So in picture C, this is the fear test that has been done: flexion, adduction and internal rotation. And the last test that this examiner is doing is the pace test, where the patient is asked to abduct the knee against the resistance provided by the examiner. So this will also cause pain over the piriformis. So these are the few provocative tests that you can do. So coming to the differential diagnosis, so first thing you should rule out is a radicular pain, especially L5S1 disc herniation can also cause pain over the buttock, with radicular pain going towards the thigh and to the leg. So another is common problem is SI joint dysfunction or inflammation can be one of the differential diagnosis. But I usually follow this picture while going for the differential diagnosis of pain, any patient with buttock pain. Okay, so when I ask the patient to show where the area of pain is, And if the patient usually uses the whole of the palm and put that palm over the buttock, and so this is the area of pain, so that is basically a non-specific type of pain. So in this non-specific type of pain is usually referred like this by the patient, so they cannot pinpoint the area of pain, but with whole of the palm they will just put over the buttock area where there is painful. So this can be a referred pain or non-specific pain. So referred pain can be secondary to lumbar stenosis like radicular pain or lateral foraminal stenosis, or it can be pain can be from the facet joint, lower facet radiating over the buttock. And another condition can be myofascial pain with referred pain in this area apart from the piriformis. And another is cutaneous disease like herpes zoster infection over this area can also produce pain. And in these conditions patient usually shows put whole of the palm over the buttock. Okay, then another group of patient can be then can show the pain with the finger. So here if you see these three pictures, the patient is pinpointing the area of pain over the bottom where there is painful. So when he does that, we basically divide this buttock region into three different places: upper one third quadrant, middle one third quadrant, and lower one third quadrant. So depending upon which side the patient shows with one or two finger, then the differential diagnosis differs. So if the patient is showing with one or two finger in the upper quadrant of the buttock, then problem can be over the sacroiliac joint, or it can be superior cluneal neuropathy. Okay, so if the patient points in the upper part of the buttock. So if the patient is pointing in the middle part of the buttock, then the pain can be of piriformis syndrome, or it can be secondary to cluneal neuropathy, or either superior or middle cluneal nerve neuropathy, or it can also be sacroiliac disease or coccydynia that we just discussed. So in these conditions, patient usually points at the middle part of the buttock. Okay, so sometimes patient can point at the lower one third of the buttock. So in these conditions, the condition that can cause the lower one third of the buttock pain can be posterior femoral cutaneous nerve neuropathy, or problem with the obturator internus muscle, either tendonitis or bursitis, or it can be hamstring tendonitis or ischio-gluteal bursitis. So these are the various differential diagnoses that you can think of if the patient comes with chronic or acute buttock pain. So depending upon the how the patient shows you where the area of pain, the patient the differential diagnosis. I usually follow this picture, and it always gives me a good diagnosis if I'm using this picture as a guidelines to check the differential diagnosis of buttock pain. Okay, so regarding investigation, previously before the introduction of ultrasound, it was purely it was clinical exam diagnosis. But after incorporation of ultrasound in pain practice, we usually see the piriformis with ultrasound. And you just saw how easy it is to identify the piriformis. And you always check the contralateral side so as to check the differences between right and left side. Typically we can see in piriformis syndrome the thickness of piriformis will be more than 1 centimeter. So and the 1 centimeter is a cutoff point for measuring the piriformis, and it is usually measured at the level of medial tip of ischium. So while measuring the thickness of piriformis muscle, we usually measure at the medial end of the tip of the ischial spine. So this is the supposed ischial spine, this hyperechoic structure, and this mustache shape is the basically piriformis muscle origin from the sacrum and inserting to the greater tuberous trochanter. And we basically measure piriformis at this site with the medial end of the tip of the ischium. So this is the site of measurement of the piriformis, and the position of the hip is usually abducted while measuring this. Okay, and this test has sensitivity of more than 94% and specificity of more than 87%. So this is one of the tests that we usually see commonly done in the clinical practice. Another thing you can do is you just can give diagnostic block with a small amount of local anesthetic agent or inside the piriformis, and see the relief of pain. So that can be also another diagnostic investigation. to check whether there is a piriformis syndrome or not. In rare cases, we go for MRI, especially if the conservative management or if the initial intervention is not giving you good result as you expected. So in these conditions, you can go for MRI to find out other causes of piriformis syndrome like metastasis or precoccygeal epidermal inclusion cyst, these things, or if there is neural structure causing piriformis symptom. So these conditions you can go for the test of MRI. So in MRI you can see the thickness of the piriformis muscle is increased. This is the left side. This is the here, if you compare left and right side, here the thickness is small, but here if you see at the side of arrow, this is quite thickened. So this can be a cause of piriformis syndrome in case of MRI. Or sometimes if you are too confused with it, whether it's a radicular pain or MRI shows there is disc protrusion, and we can also go for the nerve conduction test for in rare cases where you fail to reach the diagnosis. So these are the various investigation that you do. Always go with ultrasound. In 90% or even 98% of cases, ultrasound will give you good diagnostic evaluation. If it's not helping, then you can go for the MRI or nerve conduction test. Okay, so regarding the treatment modalities, usually conservative management is preferred if the mode of onset or duration of pain is acute or subacute. So starting with non-steroidal anti-inflammatory drug, we can mix this with muscle relaxant. Baclofen or thiocalcicoids are excellent muscle relaxant. We usually give them for 10 to 14 days, the muscle relaxant, and non-steroidal anti-inflammatory drug for 5 to 7 days. And we also tell them to put some heat and apply some ointment, NSAID ointment over the painful area, and always go for physiotherapy. So physiotherapy has an excellent result in patient with acute or subacute piriformis syndrome. Okay, so if the conservative management with medicine and physiotherapy is not helping, then you can go for intervention management. Usually intervention management previously, before incorporation of ultrasound, was done under the guidance of fluoroscope. I have incorporated one slide of that also, but after for last 2 to 3 years or 4 years, I have not done any piriformis injection under the ultra fluoroscope. I'm using ultrasound, which is very easy bedside and it's of less hazardous. So ultrasound guided, we can go for trigger point injection with or without local anesthetic agent. We can also go for, some prefer injecting steroid and local anesthetic inside the piriformis, especially the orthopedician, they prefer using steroid. And sometimes if it is chronic and if the trigger point and injection of steroid is not helping, we can go to the buttocks injection into the piriformis. That has shown good result, but the main problem is the result is very short lived, 3 to 4 months only. And there has been few evidences, very low evidence with PRP injection in piriformis, or people are also going for pulse RFA, radio frequency ablation, or extracorporeal shortwave therapy. These things are all under studies, and they have given us a very low level of evidence, so these are not advocated. Okay, sometimes we may require surgical decompression, especially if the sciatic nerve is coming within the piriformis or other variant, except from if you see the classification, except grade type A, all other type can go for the surgery if the nerve is being compressed by the piriformis too much, or if the problem is resistance to all the conservative management and minimally invasive management, then sometimes patient may require surgical decompression of the piriformis also. And we can also go for MRI to see whether the cause is any cancer metastasis or other thing, if the conservative management and initial intervention management is not giving us good result. Okay, so regarding complication, so complication of injecting local anesthetic in the piriformis can cause sometimes cause sciatic nerve block, because sciatic nerve is just below the piriformis in 90% of the cases. And sometimes it can cause injury to the surrounding structures, especially inferior gluteal artery artery, or there can be transient increase in pain, because while giving local anesthetic, pain will be less, but once the local anesthetic duration wears off, then patient pain can be exacerbated for a few days time. So these are the complication of local anesthetic injection. With buttocks related complication are basically all of the above, plus they might have a flu-like symptoms, or there can be worsening of muscle pain for few days, or there can be dry mouth or dysphagia, or sometimes there can be piriformis muscle atrophy, or there can be transient numbness sometimes. So these are all complication associated with injection of buttocks. And regarding steroid injection, it is said that there might be muscle atrophy at the side of the piriformis, but I have yet to encounter any. I've searched for lots of article regarding this, but I haven't found any relationship between the steroid injection in piriformis and muscle atrophy. But this is a theoretical complication can be there, or there can be. We all know the injection of steroid will transiently increase blood sugar. Especially, we have to be careful in diabetic patient. Blood pressure, increase in blood pressure can be due to the injection of steroid. Hormonal disbalance can be there, or there can be loss of fat at the site of injection, or facial swelling or skin rashes are all complication of injection of steroid in the piriformis area. So if we are going for ultrasound guided block, especially for the piriformis diagnostic evaluation and for the treatment, normally the evaluation is done in prone position as you saw in the picture, and we usually use curvilinear probe of depth about 5 to 6 centimeter. And usually in this, our home page is always posterior superior iliac spine of the affected part of the buttock. So we put our probe just over the posterior superior iliac spine and gradually move our probe downwards and more laterally. So initially we can see the hyperechoic line of iliac bone, and as we move our probe downwards and downwards and laterally, there will be a breakage in the continuity of the iliac bone. So that means we are over the area of greater sciatic notch, and in the lateral aspect we can see also curved ischium. So in this view, we can see a nice hypoechoic mustache-like muscle extending from the sacrum to the going towards the greater trochanter of the femur. And when we achieve this picture, we can slightly rotate our probe, the lateral aspect of the probe, along the align the probe along the long axis of the piriformis muscle, so as to see the whole length of piriformis. And you can also see sciatic nerve and as well as inferior gluteal vessel just below the piriformis. And we can confirm that the muscle is piriformis by basically doing the dynamic movement of the leg, rotating the leg, more internal and external rotation of the thigh can be done, leg can be done, which we can see the movement of the piriformis. Okay, contraction and relaxation of the piriformis. And if needed, we can inject the local anesthetic or buttocks, or just do trigger point injection. In this view, the needle is usually brought from lateral to medial aspect, and it is usually injected in the medial aspect of the piriformis, where the bulk of piriformis will be more. And the another reason while for injecting the medial aspect of the piriformis is usually the sciatic nerve is in the lateral aspect of the piriformis, in the below and lateral aspect. So more muscle bulk will be in the medial aspect. So while you are injecting any drug or doing trigger point injection, so you should always target the medial aspect of the piriformis muscle. Okay, so this is the picture. Here you can see our home page is at the site of A, that is posterior superior iliac spine. And when we put our probe here, this is the typical USG finding. Here you can see the iliac crest, whole of the iliac crest, and gluteus maximus, medius and minimus muscle very nicely seen. And once we get this picture, we gradually move our probe downwards and more laterally. Then when we do that, we can see suddenly there will be a breakage in the continuity of the iliac bone, and you can see hypoechoic like mustache like muscle extending from the greater sciatic notch towards the lateral aspect. And you can also see ischium being curved. So this is the piriformis muscle. And once we get this picture, then we can rotate our probe along the long axis of piriformis. That is, we have to rotate the lateral aspect of the footprint more in the caudal direction. So in this, when we do this, nicely piriformis will be seen. And you can also appreciate the other muscle are basically hyperechoic. So if you see the gluteus maximus and other muscle, it is hyperechoic, but piriformis is typically hypoechoic. So nicely you can see easily piriformis. And sciatic nerve is just below the piriformis, and you can also use color Doppler to see superior gluteal vessel as well as inferior gluteal vessel. Okay, so this is the how you examine the see the piriformis by ultrasound. And this is the picture where you can see intervention is done here. I think he is injecting local and steroid into the piriformis, and as you can see he's using the curvilinear probe, and the direction of probe is along the long axis of the piriformis, and direction is of needle is from the lateral to the medial side. And here also, here you can see the needle coming, and you can see tip of the needle in the main bulky area of the piriformis. So the examiner has chosen the medial aspect of the piriformis where it is bulkier. Okay, and the sciatic nerve is, you can see, in the lateral aspect of the piriformis. So the injection site is always in the bulk of the muscle in the medial aspect, and you can also see the direction of needle from lateral to the medial side into the substance of the piriformis. Okay, so before when I did my fellowship, we used to give lots of piriformis injection with a fluoroscopic guided injection. I haven't done this for last 2-3 years, but we should know this. Okay, so this is the fluoroscopic guided injection of the piriformis. Here the our main entry point is just over the 1 o'clock position of the acetabular cavity. So here, this is the acetabulum, this is the head of the humerus, this is the AP picture. So if we put a needle just over the 1 o'clock position of the acetabular cavity, then when we touch the bone and we just retract the needle 2-3 millimeter, and if you give dye, you can see beautiful distribution of piriformis coming from medial to lateral aspect. So this is the dye distribution of piriformis. You can see piriformis coming from the lateral aspect of the sacrum towards the greater trochanter of the femur. So this is the AP view, and this is the lateral view. You can see the injection, and this is the piriformis coming from origin to insertion. So this was what we used to do in past, but nowadays we are going for the ultrasound guided injection. Okay, so thank you very much. Okay, so this ends my slide of this one. So we can start discussion if I think sir has already left now. Hello. Hello.
Yeah, we hear you, sir.
Okay, so both cases that I have presented, tailbone pain and piriformis syndrome, are one of the most common causes of the buttock and lowest back pain. So is there any questions or any discussion that you want to do regarding both of the cases scenario? You are most welcome.
Sir, good evening, sir.
Good evening. Good evening.
Sir, in
Joy.
case of Pfeiffer syndrome, the role of hypertonic dextrose, sir.
Prolotherapy, there are very low evidence of prolotherapy. We usually go for the trigger point injection is the best, as well as injection of steroid into the local anesthetic and steroid. We can go for prolotherapy, but I have included in the PowerPoint also PRP injection or dex prolotherapy or even radiofrequency ablation. The literature are coming up, but the results are not that promising. Simple
Okay, sir.
trigger point injection will have an excellent result.
If in case of steroid, which steroid you will prefer, sir? Soluble or depot?
Using soluble, using non-soluble, because it will provide the long duration of action. So I usually go for
Okay.
the, apart from
Like
neck, head and neck, in head and neck, in all other region, I usually go for the particulate steroid for a longer
particular
duration
steroid.
of action.
The
Okay.
particulate steroid will be around the muscle, sir?
People are I don't give steroid into the bulk of muscle, but literatures are there which shows that intramuscular injection, that is injection of local and particulate steroid within the substance of piriformis. I usually go for only trigger point injection. I don't go for steroid injection in the piriformis, but the literature shows also we can give steroid, particulate steroid or soluble steroid in the intramuscular region, not in the tendon, but in the muscle. Into the substance of piriformis.
Sir, regarding coccydynia,
Uh-huh.
when can we go for MRI? Any specific features we can identify so that we can go for MRI?
What I suggest is normally if your conservative management is not giving you a good result, okay, normally what you do is you give your NSAID and give her him or her coccydynia pillow, adjust the augment the sitting position and go for physiotherapy. If these things are not relieving, then you go for the intervention, and even if with the intervention the results are not good, that means something is different, reason might be there. So then that is the time for the patient to go for MRI. If the normal conservative management and normal intervention is not helping, then only go for MRI, because it's very expensive, and usually the cause of coccydynia, apart from fall injury, is like only 1%. So for that 1%, it is going for MRI is not ethical. So if your conservative management is not giving you good result, and or if you suspect any if you have any red flag in your mind, then only go for MRI, not routine as a routine practice. Routinely you can go for a X-ray, lateral X-ray of the pelvis. That would be a routine investigation of choice, or dynamic X-ray of the coccyx in sitting or standing. That can be a routine examination, but not MRI.
Sir, okay, sir. What about the manipulation of the coccyx, sir?
It has a very good result. So even if you study the World Institute of Pain guidelines regarding treatment of coccydynia, they have studied two different results. One, they have given only infiltrate the coccyx with local anesthetic and steroid. In another group, what they have done is, in addition to the injection of steroid and local anesthetic and steroid into the coccyx, they have further sent the patient for manipulation of coccyx to the physiotherapy, and those patient who has gone for injection as well as manipulation showed excellent result, or 80% result was there. So I usually send all patient for the manual. If the patient onset of pain is acute or subacute, I usually send for the manual mobilization of the coccyx.
Okay, sir. Thank you, sir.
Welcome.
Sir, how is manual this thing is done?
So there are two things. One, you can wear gloves and you can put your one finger over inside the rectum and hold the coccyx and just move the coccyx. Because if you, there are two joints. One is sacrococcygeal joint, and another is first intercoccygeal joint. These are the two mobile joint. So you can gradually, slowly move the coccyx, or you can just press the coccyx. If you don't want to wear gloves and put your fingers intrarectal, then you can just move your coccyx, as I showed in the picture. You can just slowly manipulate the coccyx. We can press the coccyx and release the coccyx, and press and release. So few times you have to do morning and evening, along with application of heat, and as well as a non-steroidal anti-inflammatory drug. That has a good result. And another thing I have noticed is, if you send the patient with physiotherapy and you are not the physiotherapist, so physiotherapist will have other exercises. Especially they will teach the patient to bring the knee towards the chest. That will also help in patient with coccygodynia. So it has a very good result if you can send the patient to physiotherapist in early phases of the pain. It has a good result.
So one more question, sir. So in
Please.
coccygodynia, sir, in the point where we are giving local injection or steroid is like same the place we are doing RF.
No. That is another. We are injecting local and steroid around the coccyx. So just palpate the coccyx, okay, or in the Siam, get a lateral view, and over the coccyx. okay, over the area
You
of
don't have to
coccyx.
give any dye or something.
No. That is second step. If your infiltration of local and steroid around the coccyx is not helping, okay, then only
Just
you,
blindly we have to do around the coccyx.
yeah, blindly not, with the help of fluoroscope.
Yes, sir.
With the help of fluoroscope, we are doing, because in
How much
front of it,
steroid and
there is,
local we give there, sir?
huh?
How much
You
steroid and local we give there, sir?
about 3 to 5 ml. Total volume is 3 to 5 ml and 40 mg of methylprednisolone or this triamcinolone acetate will be with a good choice. 3 ml of local anesthetic and 1 ml of steroid locally infiltrate around the coccyx. That is the first choice that you do, along with the
So is there any particular point we should hit, sir, or matlab around the just coccyx, sir, we should?
just around the coccyx where
And in
the
some seconds,
complaining of pain. And if that is not giving you a satisfactory result, then only go to the ganglion impar block.
okay, that
And
is done with the help of a dye.
yes. That is done under, because here our needle is going in front of the sacral plate in the pelvis. Okay, so there is rectum and other structure, intrapelvic structures. So, and to avoid injury to those structure as well as to locate the ganglion impar, we have to give dye.
Where?
If you are going for a ganglion impar block, for diagnostic as well as therapeutic, or while going radiofrequency ablation. Here you have to give dye, not
So
for
that
local.
yes, sir.
Yeah.
So that ganglion impart, we for diagnostic or therapeutic, we can again give local plus steroid.
Yes. You can give local and steroid, or you can go also give like alcohol or phenol, chemical neurolysis if the diagnostic test is positive. You can do double diagnostic test, one with lignocaine and another time with bupivacaine, and see the duration of pain relief. These all things can be done. So once, if the local anesthetic agent is giving good pain relief for the particular time, so if you are giving lignocaine and pain relief is for 45 minutes to 1 hour, you can check with bupivacaine and see the prolongation of pain relief. And if you are sure that ganglion impart block will give him a good result, then you can add steroid, or you can go for chemical neurolysis with alcohol or phenol, or even go for radiofrequency ablation. Depending upon the gadgets that you have in your clinic, you can plan
Yes, sir.
accordingly. And if that is not helping, then next step would be going for a caudal epidural steroid injection. So I've shown in the PowerPoint no algorithm for the coccydynia. So you just
Yes,
follow
sir.
the algorithm, but always go for conservative management before poking needle around the lower part of the body. Okay, always I usually go for conservative management before going for the intervention.
Excuse me, sir.
Yes, Madhura.
Sir, for how long can we continue the conservative management? Like, and when do we decide to go for intervention?
Always just see the result from the patient. If the patient is happy, see, like if you are given ganglion impart block and patient is having good pain relief for 3 to 6 months, you if the patient comes with pain again, then you can a conservative management, see the response of the patient like in any other cases, give drugs, see for a month or two, so that the patient's lifestyle should not hamper. We should not go for conservative management for months and months and months, because nowadays everybody has to have an active lifestyle. They have to go to office, and they cannot go to office with the same pain for a year or more. Okay, so see the discuss with the patient. If you don't want to take medicine, or if the physiotherapy is not helping, then shift to the intervention management. Um, but it all depends upon the response of the patient with the conservative management.
Sir, and then after, when we start intervention, injection with steroid and local, if it's giving good result, like for some time it will give, and again after some time if it relapses, can we go for radio frequency? Like, when do we decide to switch in that modalities?
Radio frequency is for another thing. The if the pain is mainly, the pain is nociceptive pain, okay, in
Okay.
coccyx. So the radio frequency ablation of ganglion impar will not take care of most of the part. It is mainly for sympathetically mediated pain. Okay, so coccydynia, most of the time it is nociceptive, or the structure that is around the coccyx is giving pain. So in that condition, normally ganglion impar block will not help that much, only 20 to 30% only it will help. So what we do is, the area which is inflamed after fall injury, there can be injury in the ligaments around the coccyx that is holding the coccyx together, or in those area we just give infiltration of local and steroid. So if that is not helping, then only go to the ganglion impar block, thinking that there are, you have already seen in the differential diagnosis. Okay, so that is for nociceptive pain of, if there is arthritis, or if there is a vascular necrosis of the coccygeal, that in those conditions the local and steroid will help. In those conditions, radio frequency with ganglion impar will not help. If the initial local and steroid is not helping, then the pain can be sympathetically mediated pain, and that's why we are going into the ganglion impar and blocking the sympathetic fibers. Okay, sometimes it can be mixed, nociceptive component is also there, and other autonomic component can also be there. So it depends upon what is the main cause of pain. So at not all the time ganglion impar block will work. Ganglion impar block will work only if the patient has predominantly sympathetically mediated pain arising from the coccyx, not for nociceptive pain. So
Okay, sir.
always for nociceptive pain, target with local and steroid. And I've advised to use particulate steroid, because in our part of the world, we are not poking that place in every 2 to 3 months. We want the patient to have a better, longer duration of pain relief, and that is the reason why we are choosing the particulate steroid.
Okay, okay, sir. Thank you.
Okay, so always first is conservative management. If it fails, then local infiltration of steroid and local anesthetic in and around the coccyx. Third is only ganglion impar block and radio frequency. Fourth is caudal epidural. Okay, so these are the algorithm of treatment of coccygodynia.
Excuse me, sir.
Yes, yes, Jaya Jaya.
Sir, actually, please show once again that piriformis, how to give injection, where to give injection.
Piriformis. Okay, I'll share my slide. Okay, I'll just stop recording first. Okay, so let's continue recording. I'll share my piriformis slide. Okay, so is it visible now? Is the picture
Yes,
visible?
sir.
Okay, so
Yes,
if
sir.
this is the piriformis, if you see the right side of the ultrasound picture of piriformis, this whole muscle is piriformis, hypoechoic structure. Can you see a mustache-shaped hypoechoic muscle
Yes, sir.
extending?
Yes.
So in the medial aspect, the bulk of muscle will be more. Okay, and in the lateral aspect it will be more tendinous, and the bulk of muscle will be less. So your safe part will be the medial aspect of the piriformis. Here you can see the tip of needle is exactly where I put my marker, and you can see injection coming from lateral to medial into the piriformis in the main bulk of muscle. Another reason for choosing medial aspect, or medial 1/4 of the muscle, is you can see sciatic nerve is in the lateral aspect of the muscle in this area. So always it's good to inject the medial aspect of the piriformis, where the bulk of muscle is also more, and we are away from the sciatic nerve. So that is, or if you see in this picture, so this is the lateral aspect, ischial spine is the lateral aspect. You can see a mustache like muscle here. Our injection is over this area, around this area, in the medial aspect, not in the lateral aspect where the bulk is less and it is very much close to the sciatic nerve. Here also you can appreciate, okay, sciatic nerve is this one, big nerve. Okay, this is inferior gluteal vessels. So injection site would be in the more medial aspect of the piriformis, this part where the bulk of muscle is more. Could I clear you? Is
Yes,
this
sir. Yes, sir. Yes, sir.
okay?
Thank you, sir. Thank you very much.
Always welcome us.
So you were telling something about multiple this pricking.
Yes. Always go for we are just like trapezius and any other muscle which is causing spasm and causing pain. We can just relax the muscle by doing trigger point injection. This is piriformis syndrome is one of the is a type of example of myofascial pain syndrome also. So muscle which is located at the buttock is contracted
Yes,
and
sir.
it's angry. Okay, so just like any other muscle in the neck or back, we basically do acupuncture, like breaking the trigger points with the multiple puncture of the trigger zone. That is what I do usually. I don't mix that with local anesthetic or steroid. And in 90% of cases, if you just poke the needle into the trigger points of the muscle, that will give a good pain relief for a long duration of time. And we can repeat this. We can call the patient in follow up for after 2 to 3 weeks and see the result. If the first episode session has given him good pain relief more than 70%, then we'll not repeat the injection. If the pain relief is 50%, then we'll tell the patient, would you like to go for another session of piriformis trigger point injection, or you will continue physiotherapy. So depending upon patient choice, we can also repeat the procedure, and depending upon the pain relief with the first session of injection, we can also repeat the injection.
The
But
trigger point
Sir,
injection, sir. The
uh
multiple injections at multiple sites, or the particular site multiple injections, multiple time we have to prick, sir.
so depend where is the trigger point, what is the
So
more
like neck, sir. Like neck, sir. Most of the patients come with this, sir.
so around the trigger point. I usually go for 10 to 15 pricks in the area which is more tender, and around the area which is more tender.
With
Not
one needle, sir. Not multiple needles, sir.
not multiple needle, same needle. I
Huh.
usually poke in the site of trigger point and around the trigger point with while by using a single needle, not multiple needles.
And what should
sir,
be the
which
depth,
date,
sir?
sir?
Depth, sir.
That depending upon where your target is. So if it is trapezius, depth is
Trapezius. Most of the time, trapezius patients
yeah,
come,
it's
sir.
very 1 to 2 centimeters is more than enough.
More than enough. Okay, sir.
Sir,
No
Because
need
which
to
gauge
inject any
needle, sir?
local or steroids,
if you're
sir.
going for piriformis, then depth should be around. You have to use spinal needle, 26 gauge, 9 to 10 centimeter spinal needle, and the depth will be around 5 to 6 centimeter. So depending upon site of trigger. In piriformis, you usually go with the 22 gauge, 10 centimeters spinal needle, and for trapezius, like, you can use any ordinary needle like 21 gauge, like 10 cc. There is a 21 gauge needle. No, I usually use that needle.
Okay, sir. Okay, thank you.
So is it done ultrasound guided or just
Blind.
If
blindly we are doing
yeah, I usually go with ultrasound just for safety of
it?
myself, and can show that to the patient also. The beauty of ultrasound is right at the table you can show the procedure being done in the real time to the patient. But it also depends, like if the patient is too scared, usually they would not want to see the needle being poked. Usually with ultrasound, I suggest everybody to use ultrasound, but we can use for trapezius, we can go for blind procedure also, no issues.
The poking multiple times, it's in itself, it must be very painful, sir.
No. In the main pain generating site is skin and subcutaneous tissue. Muscle doesn't have any nociceptive fibers. Okay, nociceptive receptors. Okay, you can, if you remember in anesthesia, we can just give the if the spinal anesthesia fails, we can just give a tap block and go for the surgeon can
Mm.
infiltrate the skin and proceed for the cesarean section. No, okay.
Yes, sir.
Once the main receptors for pain is in the skin, so once we give local in the skin, then muscle in the muscle there are no pain receptors or
Okay.
very few pain receptors. You can easily poke the once you give local anesthesia at the site of entry in the skin, no need to give local anesthesia in the muscle.
So we'll give a local at this first point of entry, and then we
And
can.
then wait for a minute for the local anesthetic to act, And then
Yes, sir.
the same entry point, we just redirect the needle in multiple direction. First poke at the site of pain, and you can gradually increase your site of injection by just changing the angle of the needle.
Like circumferentially, we can poke.
Yes, yes,
Or,
yes.
okay, sir.
And you can see a jump sign once the needle pierces the muscle which is giving problem, or if the trigger point is encountered with the needle, you can see the jump sign. That means spasm of the muscle once it is poked. So that is a very good sign that tells you that you are at the right spot. Jumping of the muscle, that is known as jump sign.
Okay, sir. Like it should be the first, matlab in the algorithm, this should be the first treatment if conservative fails for
Yes,
piriformis.
yes, if conservative management with physiotherapy and lifestyle change and NSAID fails, then trigger point injection will be the first choice. And depending upon your choice, you can add local anesthetic agent while doing trigger point injection. That is also good. Or you can also add a bit amount of steroid, whether it's a soluble steroid or particulate steroid. That is also very good. If this condition is not relieving, then you go for a buttocks or other things like even surgical excision of the piriformis. If it is chronic and if the conservative management is not helping.
Sir, I have a question.
Yes, Madhura.
Sir, if the patient is having bilateral pain, like in the buttocks, one side it's due to piriformis syndrome and other side because of sciatica, then how will we proceed, sir, with the treatment? Like both mimic, like they have the same symptoms, plus pain at the same time.
So here two or three things are mandatory. Okay, here you have to understand the which
Sir,
pain is
like, is
which is
that condition possible? Like, I
no, no.
haven't seen that.
I want to tell Madhura as well as all the students, so just don't try to rush to the intervention, okay? So piriformis syndrome can be better with physiotherapy. And we also, for lots of PIVD cases, as we know, 70 to 80% of PIVD cases are also relieved. Spontaneous relief will be there with physiotherapy. Okay, so the answer to your question is depend upon the severity, duration of severity, as well as the duration of pain, the severity of the pain. So if the patient is having bilateral pain and the duration is just 2 to 3 weeks, I would usually go for conservative management, go for NSAID and pregabalin, as well as go for a back school exercise as well as piriformis stretching exercises. Okay, so that would be my line of treatment. But if the patient comes with 2 to 3 years of pain in the same direction, then I will go for the intervention. With it depends upon the duration of pain that the patient is having. Okay, so I'll go for the intervention. And the first intervention that I would choose in this patient is transforaminal epidural steroid injection of the area of sciatic, where the nerve impingement is there. So that would be my first intervention. And if that is not if that gives a good pain relief in the sciatica part, then only I'll again in second setting I'll go for the trigger point injection of the piriformis. Here also I would like to remind that I'll also ask which side pain is giving him more trouble. Sciatica is giving him more trouble or piriformis, and depending upon the pain that is giving him more trouble, I would target that area. If the piriformis leg is giving more problem compared to the sciatica leg, then I'll go for the trigger point injection. But for that, the duration should be more than 3 to 4 months, and the conservative management should fail. Okay, and if the sciatica is giving him more problem compared to the piriformis, then I'll go for the transforaminal, either ozone or epidural steroid injection. So question, there are 2 or 3 factors. One is duration of pain the patient is having. Second is whether the conservative management has been started or not. And third is which leg is giving him more problem, sciatica or piriformis, pseudosciatica. So that will determine your line of like management, whether go for conservative or choose intervention. Could I answer you, Madhura?
Sir, yes, sir. Thank you, sir.
Always don't forget to think of conservative management with physiotherapy if the time is appropriate. That is, if it is acute or subacute and pain score is tolerable, then I would like to go for conservative management with physiotherapy if I was patient.
Okay, sir. Thank you.
Sir, can we see the pain the other way around? The sciatica starting first, then piriformis being presented. Can the piriformis be secondary to the nerve pain? Because in nerve pains, we try to compensate with postural change and all.
Yes. Because most of the time, like as I've already mentioned, one of the nerve supply to the piriformis previously, we used to think that only nerve to the piriformis is the only nerve supply to the piriformis. But nowadays, recent studies have shown that two or three nerve supplies to the piriformis. It can be like it can be superior gluteal nerve, or it can be branches from S1 or S2 ventral rami. So if there is a nerve impingement, basically L5S1, it can cause piriformis pain as well as sciatica pain. So in this condition, if the sciatica is there in the same leg, then transforaminal injection, simple transforaminal injection can give good pain relief of both piriformis as well as sciatica. But if the pain is in different places, so sciatica is in the right side and the piriformis syndrome is in the left side, then you just ask the patient which is giving them more problem. So if sciatica is giving more problem, then you can go for transforaminal in that leg. If piriformis is giving more problem, then you can go for a trigger point injection in that buttock. But if it is in the same place, then first will be transforaminal epidural steroid injection, because impingement of S1 nerve root can also cause piriformis pain, as nerve supply in 80% or 85% of the time comes from S1 ventral rami. Okay,
Thank
Santi?
you, sir.
Santi?
Yes, sir. Thank you, sir.
Thing is in the same place, I would suspect that it is a sciatica and go for transforaminal injection either at L4, L5 or L5S1, whichever is giving the patient problem. Because if you see the nerve supply, ventral MI of L5 can also supply to the piriformis, or ventral MI of S1 or S2 can also supply piriformis. So it can be secondary to nerve impingement of L4, L5 or L5S1. So if I can take care of that problem, it can relieve piriformis pain. So so two things can be killed with one stone. Two birds can be killed with one stone.
The coccydynia, when we give the injection, sir, so
Mhm.
we use the spinal needle or the normal, like
Normal needle. It is
normal
I
needle if can be
use
done, sir.
the 21 gauge 1 inch needle because it is very much superficial. We
One
don't
inch needle, sir.
Yeah,
The one.
1.5 inch needle. That normal needle we get in the 10 cc syringe.
Okay,
That is
okay,
more than enough
okay, okay,
because it is very much superficial.
okay.
Sir, in coccydynia, in sitting posture, when we are taking, is it should be 90 degree, or how much, sir, it is? Like sitting,
In sitting, I couldn't get your question.
like, uh, is there any particular, like, how much, is a proper, the knee should be bent at 90 degree, and the sitting posture like that, or
For coccydynia, for physiotherapy, or you are talking about
no, no,
physiotherapy?
no, X-ray, lateral X-ray we are taking
Sitting 90 degree. If you are
90.
going for a dynamic X-ray, standing and sitting like normally, like you sit in the chair, but with pressure over the coccyx. That is slightly in extension, like loading your back like this. Knee
Okay.
knee 90 degree, but body more than 90 degree flex. Because when you do that, this only the coccyx will come in contact with the chair, so that can change the direction. So 90 degrees, I think 90 degrees good. Knee
Okay.
bend
Thank you,
90
sir.
degree and body also bend, and the thigh also bend at 90 degree.
Okay. Thank you, sir.
Any question, Eva? Are you there, Eva? So, any questions regarding piriformis? It is both of the clinical scenarios are very commonly seen in the clinical practice. Okay, so sometimes, especially piriformis syndrome, they can mimic you as a sciatica, and you might think you can go for the MRI. And always don't forget to do the neurological examination. Check for straight leg rising test. Check for motor and sensory as well as reflexes, and ask for the characteristic of the pain. So sometimes in piriformis syndrome, you can even the orthopedicians are quite confused regarding they cannot make the diagnosis of piriformis syndrome and sciatica. So clinical examination is very much helpful, especially the neurological examination. Any questions, Sangam? Where is today? Where is Bindu? Where are you? Bindu
Good
Singh.
evening, sir. I'm here, sir.
Okay, why there is no question from your side, Bindu? Please ask few question.
So everything was perfect, sir. Understood well, sir. Thank you, sir.
Okay,
Sir,
yeah.
this trigger point injections or piriformis related any procedure, you will do in that procedure room which you are showing, sir? Like where
Use all aseptic precaution, and I usually do in the procedure room in the same place. But if I used to go take the patient to operation theater when I used to do fluoroscopy guided, the picture that I showed you, know, fluoroscopy guided piriformis injection. 3 years, 4 years back, I used to do only those procedure, and for that, all the patients should be taken to OT for a small trigger point injection. But with ultrasound, like life has become so much easier for me as well as to the patient. I usually go for all aseptic precaution, wear gloves, cap, and put the glove over the this probe, and then go for the piriformis injection right at the site where you saw me doing the scanning.
even caudal epidural, sir?
No. Caudal epidural to all into our operation theater. For trigger up to trigger point injection, or up to trigger finger injection, small injection, I go in the same chamber, but using all aseptic precautions. But other thing like caudal epidural and everything in the operating room with all aseptic precaution, using all the drapes and everything has to be, yes,
Yeah.
not in the procedure room.
Okay. So knee PRPs also we need to do in OT only, sir? Knee PRPs.
Use all aseptic precaution and do in the same place where you saw me doing the examination and ultrasound examination. But it is said that one of the dreadful complication of the PRP injection is in the knee is septic arthritis of the knee. So it's better to change the patient and go to the operating room or procedure room. Uh, it is always better.
Okay, sir. Okay. Thank you, sir.
Okay. Any question? Hon Chik Cook or Kong Wang Tang?
Sir,
No,
may I
sir.
ask a question?
Yes,
Sir, may I ask a question?
Yes, please ask.
Recently, I have a patient came to my pain clinic. It's a pregnant lady. She's near trimester, entering about almost 30 weeks. But then she came in with bilateral piriformis. I diagnosed her with bilateral piriformis syndrome, have a very severe buttock pain, and several tests have been done.
Yes,
But the problem is the limitation of the procedure to be, because she have done all the conservative treatment with the physiotherapy, and due to a pregnancy, the medication is limited.
So
It's
that
not
is
much of
one of the most common complication, that is presentation with pregnant women.
Yeah.
Because pregnancy is one of the condition where there is a lot of hormonal changes. Okay, Wang. So one of the hormonal changes that the female experiences is like increase really of release of progesterone and laxity of SI joint. Okay, and some of the that is the clinical scenario that you are talking is very much common, and it is called SI joint dysfunction during pregnancy. Okay, so that is, if you can browse, you can get to the answer. So that is because of the hormonal changes, the baby has to come out from the pelvis, and the progesterone usually relaxes the SI joint, and this can cause pain in the SI joint and piriformis in these group of people. So here you can use ultrasound, Wang, and just do the SI joint injection, do the diagnostic SI joint injection with a small amount of steroid, like 20 mg of methylprednisolone, and you can also use for a piriformis trigger point injection. But ultrasound is a beautiful tool.
So should I just try with doing on the SI joint first rather
First,
than doing for yeah.
yes, first SI joint, Wang. Okay,
Mm.
because like or even piriformis, but always target SI joint. See the tenderness in the SI joint. Sometimes you can feel the tenderness just over the SI joint, because my guess is more to the SI joints, because you are referring me bilateral piriformis. Normally piriformis will be in the unilateral aspect. Okay, Wang. So if patient comes with bilateral piriformis, pregnancy, third trimester, the most probably culprit will be around the SI joint, because of the hormonal changes during the later phase of pregnancy, and that is called SI joint dysfunction during pregnancy. So you can just give local anesthetic, diagnostic test in the SI joint using ultrasound. That is the beauty of ultrasound. We can use in pregnancy and see the pain relief. So it is, if she has a good pain relief, then you can add local with a small amount of steroid. 20 milligram will not do any harm. Okay.
Mm. Mm.
See the changes within 48 to 72 hours. If pain relief is good, then you should be happy. If pain relief is 50%, still there is pain, you can give a piriformis trigger point injection at the same setting or in the second setting. That would also help. So
Okay.
my clinical diagnosis is probably hiding in the SI joint. That is
Mm.
causing piriformis irritation.
Okay. Thank you, sir.
Okay. Okay. So very nice question. Recently, I encountered my colleague who had a similar presentation that you have. So she was in second trimester. She came to my clinic with low back pain, but she was thinking that it is a muscle spasm. But while doing clinical examination, bilateral SI joint was tender, and it is not. It was not due to. It was not due to inflammatory arthropathy. Like sometimes there can be flaring up of SPA during pregnancy, so that can be also. Don't forget that. Okay, just ask the history to the patient whether she used to have similar buttock pain with morning stiffness before pregnancy also. Okay. In especially in case of spondyloarthropathy, pregnancy in 50% of cases that will relieve the spondyloarthropathy, but in 50% of cases that can aggravate spondyloarthropathy. So that can also be one of the differential diagnoses. One is normal physiological hormonal changes and joint relaxation. Second is flaring of spondyloarthropathy can also be differential diagnosis. But for that, she has to have previous history of low back pain with morning stiffness, and and most probably family history positive for inflammatory arthropathy. So these are the two differential diagnoses that I would go for in that patient.
Sir, in pregnancy, there should be wait and watch policy, or is intervention required? Or
So always wait and watch. I usually would not like to give too much of drugs, especially if the patient is in the first trimester. Even see, depending upon the trimester. So if it's in the late second or the third trimester, we can go for the paracetamol, the most safest drug. Okay. And go for even the mother would not like to go for conservative management or too much of pills, like they want to avoid too much of pills. But if you can diagnose the condition, and if you have a good knowledge of ultrasound, then use of ultrasound guided injection is not contraindicated. So you can easily use the knowledge of ultrasound, and depending where the pathology is, if it's a facet or if it's a SI joint or if it's a piriformis, you can nicely easily go into this structure and inject drug. But for that, you have to find out the culprit, what is giving her the problem, and also to choose the conservative management, see the duration of pregnancy and what is the preference of the patient. That is also a key deciding factor.
Well, one more thing in pregnancy, all these examinations and then positioning, everything is difficult in
You can
second
go
or
for
third
lateral
trimester.
side. You can inject in the lateral decubitus also. No need to go always prone. So what you can do is, if your right-sided buttock is going giving you problem, then you can, since yes, I can understand because of the position of the uterus, patient may not be able to lie prone, but it can be done easily done in the lateral decubitus also. But for that, you have to have a clean 3D knowledge of the ultrasound and its representation in your mind. So that is also vital. You can do all this procedure in lateral decubitus.
Yes, sir.
No need to go for a prone position.
Yes, sir.
Sir, sir, even for SI joint injection, can it go for lateral position, sir?
Yes, yes, yes. If the pregnant woman, it's very common. Pregnant woman with like Wang just told us, no, patient with pregnant lady in second or third trimester coming with low back pain, and most probably the problem is in the SI joint. And in these conditions, we all know X-ray is contraindicated. We cannot go for fluoroscopic guided injection, and this is the time where you can use ultrasound, knowledge of ultrasound, and give injection in lateral decubitus. Very easily you can give.
Okay, okay. Thank you, sir.
So any more question regarding piriformis, or do you see these kind of buttock pain, coccydynia and piriformis regularly in your pain clinic? Huh? Are you seeing these low back pain with coccydynia and piriformis commonly in your pain clinic? Or is it common only in our part of the world, Nepal and India?
It is common in Namibia, Africa as well.
Yes, yes, yes. Okay, that is one of the most very much common problem that we encounter, and I think today's lecture will be giving you a small insight of what to do, how to proceed, and go forward. Okay. Any question, or if you want to discuss anything apart from this too, or we can call it a day off. Unfortunately, Das sir had to go out because of some medical issue in his family. So I'm basically taking care of the question answer session. Okay. And if there is any question that is there that I couldn't answer, next time Dr. Gautam Das will definitely answer all the queries.
Sir, I want to ask about, piriformis, if there is no any tenderness during your clinical examination. Can you rule out that there is no any piriformis syndrome?
Yes, most probably, I like 9 out of the 10 time piriformis will be tender during manual examination, or the any other provocative. It need not be tender in palpation. Okay, but the provocative test that we do, like Freeburg's test or modified Freeburg test or pace test, Betty test, these tests, not it need not be all the tests should be positive, but at least few tests, 2 or 3 tests out of the all should be positive. So that can also, it is not that at all time tenderness should be there. The provocative test positive, that also means the piriformis is getting irritated or strained at some point. So these we can go ahead with injection or conservative management, and it also depends upon the history. Ananya. Ananya. So if the patient is having a history of a sitting pain, which is giving good relief with a non-steroidal anti-inflammatory drug, so in these conditions also, it need not be tender during manual palpation over the piriformis. If the provocative tests are positive, then also we can diagnose that as a piriformis syndrome. Okay.
Sir, excuse me.
Yeah.
you told there is the division of sciatic nerve into 6 different types and all.
Yes.
During that, like even if that anatomical variation is there, if the nerve is coming up or in between it is coming, in during that time also the site of injection will be same, or how to proceed during that in the such condition.
Site of injection, like 90% of the time it is like type 1 where the sciatic nerve comes below. So you have to have that thing in your mind that variation can be there. So while injecting, it is your duty to identify the sciatic nerve. Okay, sciatic nerve, you have to prevent injury to the sciatic nerve. So that's why we have to know all the various variation. Site of injection is around the medial aspect where the bulk of muscle is more. Okay, but those variation are shown to you so that you know what are the your needle can go through and through the sciatic nerve and go into the piriformis if it's the sixth type. Okay, so those variation you have to keep in mind, and you have to be able to identify the sciatic nerve, the honeycomb appearance structure, you have to be able to identify, and you have to prevent injury to the sciatic nerve. And site of injection is always not, there is no pinpoint site. It is usually injected around the bulk of the muscle in the medial aspect of the piriformis. You can prevent while injecting, you can choose the trajectory of the needle so as to prevent the injury to the sciatic nerve if there is any anatomical variation. But
Okay, thank you,
the
sir.
but the area of injection is around the medial aspect of the piriformis, and preventing injury to the sciatic nerve if there is any anatomical deviation that you could identify. It can be identified in ultrasound.
Okay, sir. Thank you, sir.
Okay. Any other more question? Niru, any questions from you, Niru?
No, sir, I'm just listening to the questions.
Okay. Samir, any questions from your side?
No, sir.
Okay, okay. So shall we call it today a day off? Should we stop the discussion?